Okay. Bismillahirrahmanirrahim. So we'll start it with a brief description of the anatomy. You know what are the contents of the thoracic cage, the things that are inside the thoracic cage. We have the ribs, which are covered by the skin and the subcutaneous tissue. And inside the rib, there are the lungs, which are in the peripheries. And in the central part, we have the mediastinum. And the mediastinum, we'll discuss it today, inshallah. It has 4 compartments, and it is usually, it contains the heart and the major vessels that are coming in the heart or going out of the heart, and the things that are in front of the heart or on the back of the heart, as well as on the top of it. So we have the anterior, posterior, and the middle mediastinum, and the superior mediastinum, that is the part above the level of the heart. And the problem we have here in the lung is it is lined by a rigid cage, the rib cage. It is very rigid. So any thing that is causing some change in the space, any space occupying lesion, or anything that is causing some pressure built in one area, it will cause, or it will affect the other side also. Like we discussed yesterday, if there is a tension pneumothorax, it will pull or it will push the mediastinum to the other side, affecting the other lung also, as well as the mediastinum. So the thoracic cage is a protective shield for these vital organs, but on the other side, if something happens, the pressure built up is causing symptoms that are because of the bony rib cage outside. Now, we discussed yesterday one of the type of pneumothorax, which was traumatic. Okay, so we have one part as a traumatic pneumothorax, and other part we call it as a spontaneous pneumothorax. Without any reason, patient develops pneumothorax. There is no trauma, there is no intervention, but patient develops pneumothorax. And pneumothorax, we discussed yesterday, it is air in the pleural cavity. So when the pneumothorax generates, when the air in the pleural cavity comes and it causes pressure, it collapses the affected lung. Lung on that side is affected and it is collapsed. So treatment is needed in cases when patient is symptomatic, and you have to take out the air out of it. Now, what is a spontaneous pneumothorax? Spontaneous pneumothorax is, as the name indicates, it is spontaneous without any reason, and it has 2 varieties. One is called a primary spontaneous pneumothorax, that is arising in a virgin lung. The lung does not have any underlying problem. And the second is the secondary pneumothorax. Secondary spontaneous pneumothorax, which is in a disease lung, like a person suffering from chronic obstructive pulmonary disease, or from tuberculosis, or from cystic fibrosis. The patients who have a pneumothorax with the background of a lung disease, we call it a secondary spontaneous pneumothorax, while the patients who don't have any previous presentation or previous lung disease, and they suddenly present with a pneumothorax, we call it a primary spontaneous pneumothorax. Now, why is it important to differentiate is because the treatment depends on the patient's presentation. Think yourself, a young man presents to you suddenly with severe respiratory difficulty, and when you are observing the patient, he's tachypneic, his chest is not moving on one side, and when you auscultate it, there is no air entry on that affected side. Now, if the patient does not have any history of lung disease, think about the primary spontaneous pneumothorax, and the reason why he developed it is because this is a condition in which there are in the lung parenchyma, within the lung parenchyma close to the pleural side, there are some bullies present, some bully or blebs are present, and usually the presentation of the patient is, he is a tall young man. Usually these are tall young people, young man, and they when you do the x-ray, there is pneumothorax, and you can find some air-filled bully close to the apex of the lung. So this is the usual presentation of these patients, and treatment is you have to intubate the patient to relieve the symptoms, and if there are still bully present, you have to remove those blebs or the bullies. You can see here in this picture, close to the lung close to the pleural surface of the lung, you can see there is an air-filled cavity or a bleb or a bulla formation, and when this bulla rupture, the air leaks and it enters into the pleural cavity and it causes pneumothorax. So if you come across such a patient, you will treat the patient, you will intubate the patient to relieve the symptom, but at the same time, you will investigate for other bullies. And if there are other bully present, you have to treat them and you have to do a surgical resection of those bully. Okay, this pneumothorax that generates, sometimes it is so intensive, and sometimes it is associated with a single one valve formation, that still it can present as tension pneumothorax. So you have to be aware that presentation can be of a tension pneumothorax. Okay, this is how it presents. Patient may have pleural, this is for tension pneumothorax. Patient will have tracheal deviation, chest pain plus tracheal deviation, and maybe the mediastinum shifting on the other side. The lung fields are hyperresonant on percussion, and breath sounds are reduced. So when you are dealing with such a case, go for intubation and operate the patient. Sorry, or intubate the patient. That is the first treatment, definitive treatment of it. What do you see in this X-ray? Can you explain what is in this X-ray? Can anyone explain what is in this X-ray?
There is a tracheal deviation, Doctor.
Where?
In the third.
See the trachea. This is the trachea. Tell where is it deviated? The trachea is deviated to the right. Okay, this is the trachea.
Left lung pneumothorax.
This is the trachea. Okay, this is the boundary of the trachea, and this is the right bronchus. Okay, what else?
There is a lot of air in left lung.
Okay, if you can see clearly, these are the lung markings. These white lines, these all are the lung markings you can see here. But here, the whole area is not having any lung markings. So this area is full of air. There is no lung field present, and the lung, maybe this is the border of the lung. This collapsed part is the border of the lung, along with the heart. It is collapsed with the heart. So this could be, this is the heart shadow. This is the border of the heart. So this portion that contains some air and some haziness, this is the collapsed lung. So you can see that in this area, there is no marking. This all area is devoid of any marking. So this is a pneumothorax, a massive pneumothorax that is causing collapse of the lung, as well as pulling of the trachea to the opposite side, or pushing the trachea to the opposite side. So it is a tension pneumothorax. Okay. What is it? Okay, this is another picture. Now there is a tension pneumothorax on the right side of the lung. You can see the trachea is pushed towards the right side, as well as the mediastinum. The whole mediastinum is curved and pushed to the right side. This is the marking of the lung. Lung is collapsed and it is pushed towards the left side. Okay. Emergency treatment is needle decompression. I have shared a video on Moodle. You can check it later, but we have discussed it before also. What is emergency treatment if the patient is in severe symptoms, patient is going into the shock, patient is not stable? Insert a needle in the second intercostal space at the mid-clavicular line. We call it the needle decompression. And the rest you have to do is, for the definitive treatment, you have to pass a chest tube. Now, as we discussed, if there are bully formation or blebs at the periphery of the lung, then we can do blebectomy, or we can go for pleurodesis. Blebectomy is we remove the blebs, and these pictures are when it is done thoracoscopically. We call it VATS, video assisted thoracoscopic surgery. And what we do it just like laparoscopy. We don't open the chest, we enter the thoracic space from the supraclavicular region, and then we operate the peripheral structures there. Sometimes we do other surgeries also, or pleurodesis also. We call it the VATS, video assisted thoracoscopic surgeries. Okay, now this was about the presentation of spontaneous pneumothorax. Now we'll move on to lung lesions that can be benign or malignant. So the lung lesions that we have, they can be the form of solitary nodules, or benign tumors, or carcinoids, or the malignant lesions of the lung. What is a solitary nodule? It is usually found incidentally when you are doing X-ray of the patient for some other reason, like patient comes for their regular checkup and they are ordered to get an chest X-ray, or the patient presented with some other mild symptom, like maybe patient presented with some chest pain, patient presented with some cough and other problems, and you do an X-ray, patient is otherwise stable, and what you do is you find some nodularity, or you find some opacity in the lung field on X-ray. Solitary pulmonary nodule is defined any lesion within the lung parenchyma that is less than 3 centimeter in its dimension, and usually they are asymptomatic. And why it is important to identify these lesions is you have to differentiate it from malignant lesions. You have to differentiate it benign lesion from a malignant lesion, because if you pick a small solitary nodule at an early stage, when the stage is just stage 1 or stage 2A, you can cure the patient. You can offer a treatment to the patient, and you can have a very good prognosis with the patient if he presents earlier. The causes we discussed, they can be tumors, they can be benign lesions, they can be benign or the malignant lesions, or they can be carcinoids. Whenever a patient presents to you with any complaint, or patient is referred to you with something suspicious on the chest X-ray, the first thing you will do, you will thoroughly take a good history from the patient. You have to take complete history regarding the patient's symptoms, as well as you have to rule out the risk factors. The risk factors for problems of the lungs, they are the age, smoking history, occupational history, and if the patient is having other primary tumors, like a problem in any other region of the body, and there are secondaries that are sent to the lungs. So you have to look for the risk factor. Again, the physical examination is very important. Just like this, you have to do a proper physical examination, not only to rule out that lesion as the primary or as a secondary. You have to look for all the other areas, because lung is a site of metastasis. So the secondaries can come from any area, and female from breast, male from prostate and colon. So you have to ask the systemic inquiry in these patients is very important, because you have to rule out whether there is some other problem going on in the body, and these lesions that you found incidentally on the chest X-ray, these are the secondaries coming from that. Okay. Okay. We order when we order CT scan for this patient, some things are very clear on the CT scan that tell us about the behavior of the lesion, whether the lesion is malignant or benign. The first thing is the nodule itself. What is the appearance of the nodule? And second is the calcification around or in the nodule. So when we talk about the calcification, a nodule that is malignant, they usually have ground glass or stippled calcification, or the calcification is eccentric away from the center. That is not a central calcification, that is away from the center. We call it eccentric. But on the opposite side, any calcification that is diffuse, central, or it is in the form of a popcorn. We call it a popcorn, a chondrite popcorn appearance, or it is concentric or a laminar calcification. We call it a benign nodule. These are most of the time, more than 50 to 60%, these are benign. So when we look at these nodules, you have to look carefully for the feature of that nodule. What is the type of the calcifications there? Second, the nodule itself. If the nodule is smooth, it is uniform, there is no halo formation around it, it is usually benign. But a nodule that has a spiculated margin, or there is a halo around it, or it has a spikes. Spiculated is actually spikes, just like you remember coronavirus. It has a spikes, just like that. Any tumor with spiculated margins, that is a malignant tumor. That nodule should be taken as a malignant. Then angiogenesis is also very important. These tumors which are malignant, they have they are very highly vascularized as compared to the benign lesions. They are not vascularized at all. Then when you do PET scan, the tumors that are of malignant nature, they take up more radioactivity, and they appear, their metabolism is increased, and therefore they take their uptake is more. While sometimes in infections or in cases where there is inflammation, the uptake is also increased. So there may be false positive result if there is associated infection. How we do biopsies of these lesions or any tumor of the lung? Biopsies can be Can you see this X-ray here? How can I remove it? This X-ray is visible to you?
Yes, doctor, visible.
This time I will share it again.
No, nothing is visible.
Now I will share it again because it was there and it was not removed. Now, okay. How to take biopsy? It is not like an abdomen. It is not like an periphery of the body that you can go and do a percutaneous biopsy. So biopsies, to take a biopsy of a lesion, you have to be very clear what is the location of the nodule and how you will approach it. We can go for bronchial route, transbronchial route. We can go for endobronchial ultrasound, and through the bronchoscope we can take bronchial biopsy, or sometimes if the good interventional radiologist is available, we can locate it and we can go for the percutaneous route in accessible lesions which are in the periphery. In the periphery of the lung, you can go for percutaneous, but usually when the lesion is central, we go for the transbronchial route. And whatever is the specimen you have collected, you have to send it for histopathology and culture if you're suspecting some infectious origin. Okay, what to do with a nodule? If you find a nodule, what should be your strategy in dealing it? This algorithm which now you are seeing, it is how to deal with a nodule. And we have two algorithms. One is for a small nodule that is less than 1 centimeter or about 8 millimeter in size. This is a cut limit. If a lesion is 8 or less than 8, we follow usually this protocol, because the chances of malignancies are very rare in this case. But if it is more than 8 up to 2 centimeter, we said a nodule is up to 3 centimeter. Okay, this is when you see it on X-ray, but this is according to the CT scan that we have made this algorithm that if you have a solitary nodule of more than 8 till the 3 centimeter or the cutoff limit, we follow the other algorithm. But this is for a nodule that is less than 8 millimeter. So what you have to do if a lesion that you found is less than 1 centimeter in size or up to 8 millimeter in size, you have to look for the risk factors. If the patient is having one or more risk factors, like the patient is chain smoker, patient is old age, patient has a previous history of malignancy or history of malignancy in some other area, then what you have to do is you have to assess the patient accordingly. If the patient is having a nodule size of about 4 millimeter or less than that, what you have to do, if there is history and patient is having a less than 4 millimeter tumor, what you have to do, you have to follow up the patient in 12 months. If it's stable, there is no additional follow-up required. If it is 4 to 6, you have to do imaging in 6 months, 6 to 12 months. You have to take the first CT scan and then you have to follow it again. If the patient is having a nodule size of 8 or 6 to 8 millimeter, up to 8 millimeter, what you have to do is you have to do the imaging in 3 to 6 months time, and then you have to take a follow-up again at 1 year or 2 years. So simply speaking, if a patient is having a less than 8 millimeter nodule and if the risk factor is present, you have 3 options. First is if the nodule is less than 4 centimeter, you will do an imaging within 1 year. And if it's stable, you will not continue any further investigation. If it is 4 to 6 millimeter, what you will do, you will take a scan at 6 to 12 months, I can say 6 to 1 year. And then if it is not causing any symptom, you will do a rescan at about 2 years. And if there is no problem, the nodule is not increasing in size, there is no change in its appearance, you may leave it. If the nodule is up to 6, more than 6, up to 8 millimeter, you have to do an imaging earlier, about 3 months time. And then if the patient is stable, repeat it at 1 year time and at 2 years if it remains stable. So you have to check for the stability by repeated scans. If there is no risk factors, then it depends on the patient's status. If the patient can afford, you can offer a follow-up. Otherwise, for a tumor less than 4 millimeter, we don't offer anything. If it is 4 to 6 millimeter, we say them to get an imaging in 1 year. And if it's stable, we don't offer them anything. If it is up to 8 millimeter, but there is no risk factor, then you can offer him to have 1 CT scan and repeat it after 1 year. If the patient has no symptom, we can discontinue the follow-up. Otherwise, if the patient has symptom, then you can go for endobronchial or other ultrasound if needed, endobronchial ultrasound or biopsies if needed. This was for a tumor which has very less chances of malignancy because the size is very small. But if the size is more than 8 millimeter, then again, you have to look for the risk factors. If the risk is high, if the risk is very high, you have to evaluate it like a proper tumor protocol. You will offer the investigations modality, the other investigation modalities. You will offer him the endobronchial ultrasound or a biopsy if needed, and we can go for PET scan. If there are no metastasis as such identified in the vicinity, you have to go for VATS and you have to go for a resection of that lesion. Now, in moderate cases, you have to go for PET scan and other investigations. And if they are negative, you just have to keep the patient under observation. You have to do CT surveillance. You have to repeat the CT scan in 6 to 12 monthly period. And if it is moderate uptake, the uptake on the PET scan is moderate, and there are some evidence that it could be a malignant tumor, then you have to go for a biopsy. You can go for endoscopic biopsy, or you can go for a transthoracic percutaneous biopsy. And if the lesion is approachable, you can go for VATS and you can resect it. The lesions with very low probability, we just keep them under surveillance. You have to do CT scan at about 3 months, 6 months, 3 months up to 6 months, then you have to repeat it after 6 months, and then you have to repeat it after 1 year. So the first CT you can offer to this patient is about 3 to 6 months period time. Then after 6 months, and then after 1 year. So if the probability is low, you will keep under the surveillance. If the probability is high, you will go for evaluation of the patient. You will go for further investigations, and the management now depends on the report of that investigation. If it is towards the malignant side, you will do a proper evaluation, and then you will treat it according to the protocol. We usually, because these lesions are small, we don't offer thoracotomies, we offer VATS, and the tumor can be resected via VATS, and you can do histopathology of that lesion. Now, these solitary nodules, as already said, that they are incidental findings. They are clinically asymptomatic and classified according to their origin. This could be epithelial origins, this could be mesodermal origins. Epithelial origin tumors or benign nodules can be polyps, papillomas, or adenomas. And mesodermal, they can be lipomas, fibromas, leiomyomas. Out of these, fibromas are commoner as compared to the other. Lipomas are actually the tumors arising from the fat between in the interstitial space, in the interstitial tissue, and the around the cartilaginous ring. And the treatment is by if you are finding such a tumor while you're doing bronchoscopy, you can excise it while you are doing this bronchoscopy. Okay, these could be vascular tumors, sclerosing hemangiomas, and when we see the CT scan finding, these nodules, they are calcified. They are centrally calcified tumors. The most of the part is calcified. This is the feature of a benign tumor. When you see such a tumor with central calcification, we have already said that these are the benign tumors. So usually the hemangiomas present like this. Now, CT popcorn calcification and fat. This is the feature of benign tumors, and hematomas are the most common lung tumors which present like this. They occur in all ages with slight male predominance, and they are slow growing nodules. CT scan appearance is very clear. When you do the CT scan, you see the popcorn appearance. I will show you in a while. We saw it before. This appearance is of hematomas, and hematomas are treated as benign tumors, and you have to, if asymptomatic, you have to do nothing for them. Okay. Okay, one or more benign tumor, or which can be converted into a malignant variety, is carcinoid tumor. The bronchial carcinoids are neuroendocrine tumors, just like other carcinoid tumors. They arise from the cells in the bronchial mucosa, the culture cells, which are the neuroendocrine cells, and they have equal gender predominant. They are equal in gender presentation. Age is about 3 to 40 years. This is the common presentation age for the bronchial carcinoid. Now, keep one thing in mind. It is one of the tumor which is not associated with cigarette smoking, along with adenocarcinoma. Carcinoid and adenocarcinoma, the relation with the cigarette smoking is very less, or there is no relation. If you take the history from the patient, patients are usually non-smoker. So a patient presenting to you with a lung lesion, which is solitary nodule, or which could be a tumor in the parenchyma, patient has no history of smoking. Keep it in mind, it could be a carcinoid or it could be adenocarcinoma. The other varieties, the squamous cell carcinoma and the small cell lung carcinoma, both starting from S, so it will be easy for you to remember. The squamous cell carcinoma and the small cell lung carcinoma, which has 3 varieties inside, they are very strongly related to cigarette smoking. And one more thing to remember is these squamous cell carcinoma and small cell carcinoma, they are centrally located. You can imagine yourself a patient who is smoking. The smoke is going through the bronchioles inside. So the central portion is around the bronchioles. So a patient who is taking too much smoking, the tumor will be within the vicinity of the bronchioles, the central tumor. The tumors will be central, and the same is the presentation for the squamous and the small cell lung carcinoma. So squamous cell carcinoma and the small cell lung carcinoma, to make it easy for you, they have tumors centrally located, and usually the patient has very strong history of cigarette smoking. Okay, now come back to the carcinoid. Just said that carcinoid, they have no relation with cigarette smoking or other environmental factors. Any question? Okay. Now the carcinoids are usually benign tumors, and most of them, they are local, but there are sometimes there is advancement in the carcinoid presentation, and patient may present to you with atypical or abnormally functional cells, and these are called the atypical or intermediate grade carcinoids. Usually are the typical or the low grade carcinoids, which resemble the normal cells, and their growth is very slow. But the atypical carcinoids, they are having abnormal cells, and they grow and spread more rapidly. So most of the time, the carcinoid that we see, they are bronchial carcinoids. They are well differentiated. They are slow growing, but in locally invasive tumor, and they have very low malignant potential. They rarely cause carcinoid syndrome. These tumors are highly vascular, and if you come across such a tumor and there are indication for surgery, we can go for surgical resection with intraoperative frozen section to check for the margins. If the margins are involved with the invasion, there is invasion of the vascular tissue, you have to rule out whether it is benign or malignant. So we do the intraoperative frozen section at the same spot. You can do it, and you can continue with your resection. If needed, you can extend it. And prognosis of these lesions is very good. The atypical carcinoids, they have atypical features. Their cellularity is increased. They are of different shapes, and there is increased mitotic activity in these lesions, and they metastasize to the lymph node. The typical carcinoids, they don't metastasize. They are just locally invasive. But the atypical carcinoids, they are aggressive, and they may metastasize to other regional lymph nodes. So for these, you have to go for anatomical surgical excision. You have to excise that, and again, you can go for a frozen section, and you can extend your limits. Okay, going on to the lung cancer as such. Lung cancer is one of the most common cancer. Previously it was said it is most common in males, but it is seen that it is becoming the most common cancer in females also. If we compare the incidence of lung cancer, it has been seen in the last 20 years, the incidence of lung cancer in males, it is either static or slightly decline. But in the females, on the other hand, the incidence is increasing, and it is making it, previously it was not so common, but now it is the second most common cancer in females after breast cancer. So it is responsible for about 25% of all cancer deaths in the United States. And it is #1 cause of cancer deaths in both the sex, the #1 cause of cancer deaths. Okay, etiologically, it is related to different factors, but the most important is smoking. 85% of all lung cancers, the patients have a very strong history of smoking. And the other factors can be aging, pollution, environmental factors, especially radon gas. It's a gas that is present in the soil, and the farmers are more affected with it. Then some predisposing diseases like COPD, asthma. Then genetic, patients having a family history of lung cancer, they're also more prone to develop it. Patients who are working in specific places, like patients who are miners or work in asbestos factories, they are also more prone to develop lung cancer. Then smokers who are inhaling tobacco, and patients who are passive smokers. The person does not smoke himself, but he lives in the company of people who are heavy smokers. So they also have the chances to develop it. Then radiation, patients who work in the radiology departments, they are tagged and they are checked annually for the amount of radiation they have received. And it has been seen that the patients, that the people who are more exposed to radiation, they also develop lung cancer as compared to the other population more. Okay, histologically, the most common type of lung cancer is adenocarcinoma, and then we have the squamous cell carcinoma, and then we have the small cell carcinomas. If we and I just told you that what is a small cell carcinoma and a squamous cell carcinoma. Small cell carcinomas are the oat cell carcinomas and other tumors, and they are highly aggressive. And squamous cell carcinoma that arise from the squamous epithelium of the bronchioles. These two tumors, they are centrally located and they have a strong relationship with the smoking. While as compared to the other variety, the adenocarcinoma, they are not related to smoking as much, and they are peripherally located. If you see the tumor in the periphery and the patient is a non-smoker, and there is no there is no presentation of some specific symptom, I usually think it is an adenocarcinoma. Okay. When we divide the lung cancers, usually we divide them as a small cell lung carcinoma or a non-small cell lung carcinoma. Small cell lung carcinoma are the oat cell carcinomas or other tumors, spinal cell carcinoma. The non-small cell lung carcinoma has commonly three varieties. One of them is the squamous cell carcinoma, the other is the adenocarcinoma, and the third is the large cell carcinoma. So you can see in this chart about 1/3 of the tumor is about 15% of the tumors are the small cell carcinomas, while more than 80% tumors are the non-small cell lung carcinoma, out of which the most common variety is the adenocarcinoma. Okay, adenocarcinoma, the most common type, is associated with non-smokers and females. This is also to be noted because the incidence of squamous cell carcinoma is more in the males, but here in the adenocarcinoma, the incidence is more in the females. It is tend to be in the peripheral lung parenchyma, and lymph node metastasis is common, just like with any adenocarcinoma. The squamous cell carcinoma, on the other hand, is the second most common type. It is seen in males, smokers. It tends to be central. And you can see when the tumor cells are seen, there is keratinization of the superficial layer, and it can be seen on sputum cytology. These tumors, they invade locally as compared to the, they have lymph node metastasis, but usually they invade locally. Adenocarcinoma, on the other hand, they metastasize earlier as compared to they go to the lymph nodes or to the other areas earlier as compared to the invasion. They don't invade too much because they are away from the area of the bronchioles, and they are more towards the peripheral side. The third variety, which is the most common third variety, is the large cell carcinoma, and they tend to be in the peripheral lung, and they often cavitate. You may have a lung lesion with cavitation, and these lesions, again, they have early metastasis. Okay, presentation usually is asymptomatic. Usually this is incidental finding. You are doing chest X-ray for some other reason, and you discover something in the lung. And usually it is a solitary mass that we find in the beginning. These patients with small single masses, they are totally asymptomatic, don't have any symptom. And when we see a patient with symptoms, usually these are the patients who already have local invasion, or maybe they have diseases spread to the other areas. So if the patient is having an incidental presentation, usually the stage of the tumor is low. You have to be very aggressive in investigating because the patient can have a very good prognosis if it is investigated properly and treated earlier. Okay, the spread of the the presentation of the tumor can be that it can be asymptomatic, or it can be because of the things that it involves. It can spread to the thorax, it can spread to the mediastinum, it can involve the pleura. The patient may have pleural effusion, they may present to you with pain, they may affect the pericardium, they can be pericardial effusion, they can cause pressure symptom on the superior vena cava, and there can be superior vena caval obstruction. There is a special presentation, it's called Pancoast tumor. Sometime we get a referral of a patient who may present in the neurosurgery department with pain in the shoulder and arm, with some problem with the finger numbness. They may have numbness of the fingers, and they present to the GP or the neurosurgery department with pain in the shoulder and pain in the arm. This is a presentation of a tumor that is in the apical region, and that is causing compression of the superior sulcus. We call it the superior sulcus tumor or the Pancoast tumor. What is happening here, the tumor that is located in that region, it is compressing the brachial plexus, and it is causing symptoms to appear in the arm. Problem is not in the arm itself, the problem is because of the involvement of the brachial plexus. And these patients, other with this, also have Horner syndrome because of the sympathetic ganglion involvement. They may present to you with meiosis, ptosis, or sometimes there is. Any question? Sometimes there is decreased sweating in the affected side. This is this patient presenting to you with referred to you from the neurosurgery department, has symptoms related to the nerves of the arm, but when they underwent an X-ray to check for the shoulder joint and other area, what you see is a mass occupying lesion or a space occupying lesion in the mediastinum or in the apex of the lung. So these patients, they may have arm or the shoulder pain. They may have symptoms of Horner syndrome like meiosis or ptosis, or absence of sweating in the affected side of the face. Or they may have, if the tumor is affecting or compressing the recurrent laryngeal nerve, there may be change in the voice. If it is affecting the phrenic nerve, there is paralysis of the affected side of the diaphragm. And if it is pressing on the esophagus that is present in the posterior mediastinum, it may cause dysphagia. So any of these symptoms can be the presentation. But when these are the presentation, think about the stage. The stage must be more than the stage of curability. Okay. There is another important aspect of these tumors. These tumors, they secrete some active substances, and the effect of these substances are in special areas, in special substances that they're producing, like ACTH producing tumors, ADH producing tumors, growth hormone producing tumors, or parathyroid hormone producing tumors. And these are more commonly seen in small cell lung carcinoma. And general features are like anorexia, cachexia, low-grade pyrexia, just like with any other tumor. But along with that, there are symptoms related to the overproduction of the hormones. Like in small cell lung carcinoma, we have increased ACTH production, increased ADH production, or abnormal ADH production. And in squamous cell carcinoma, they are more associated with parathyroid hormone secretion. The parathyroid hormone secretion is increased. So sometimes the patient presentation is because of the overactivity of these hormones. And when we do a chest X-ray or a CT scan, we find the culprit there. This is the Pancoast tumor. You can see the ptosis of the eye in this patient. And presentation is pain, upper extremity numbness or weakness, and Horner syndrome. This is the location of the tumor. You can see here. This is the location of the tumor. You can see here. Now, in any case, a patient presenting to you with a lung cancer, you have to take a thorough history. You have to do a thorough physical examination. If a patient is having productive cough and there is sputum production, you can go for sputum cytology, but usually it has little role in these cases. You have to go for imaging modalities like chest X-ray or CT scan, helical spiral chest CT, and you can go for biopsies through the endoscopic route or interventional percutaneously. And sometimes we take use of the VATS also. We do the biopsy through the VATS. The lesion should be properly investigated, and because it is if you are finding some lesion, you have to identify the stage. Why it is important? Because if the lesion is of stage 1 variety, it is having a very good prognosis. Even for stage 2, the prognosis is 50-50. But after that, as the stage progresses to grade 3 or grade 4, the chances of survival or the prognosis is not very good. So you have to stage it very carefully, and because your treatment depends on your stage. Okay, we discussed it. Okay. The staging we do is TNM staging, TNM. The TNM staging is tumor size, N is the nodal status, and M is the metastasis, or the metastatic potential of the tumor, or the metastatic stage of the tumor. The metastatic stage, if it is present, the tumor is stage 4, straightforward stage 4, and what you have to do is just targeted therapy, or you have to just do symptomatic treatment of the patient. And what is T stage? T stage is we divide the stage into different subgroups. T1 is any tumor that has tumor size of up to 3 centimeter, and we further divide it into T1A or T2A. I will share my screen with you, and then I will show you the staging, because if you see it, it is not easy. Okay, we have T stage and we have N stage. We have T1A, we have T1B, we have T2A and T2B. We have T3 and T4. Now, what is T1A? Any tumor which is less than 2 centimeter, the solitary nodule. This is the solitary nodule. Which, you can see the screen? You all can see the screen? You all can see the screen? Okay. Okay, T1A, any tumor which is less than 2 centimeter, but any tumor which is 2 to 3 centimeter is taken as T1B. Now, for T2A, we have a tumor which is about 3 to 5 centimeter in size, and T2B is any tumor which is about 5 to 7 centimeter in size. T3 is any tumor more than 7 plus, or any tumor which is gone to the mediastinum is T4. Now, here in T2, we have additional things of T2 and T3 and T4. There is a word, carina. What is carina? This is carina, the place where your trachea is dividing into the bronchi. This is called the carina. If a tumor is more than 2 centimeters away from carina, we take it in stage 2, the whole. Okay, this is for both of these. If a tumor is more than 2 centimeters away from carina, we take it in stage 2. If a tumor is less than 2 centimeters from carina, if this is the carina, if the tumor is here, that is stage 2, T2, sorry. If the tumor is here, this is T3. So less than 2 centimeters is T3, more than 2 centimeters is T2. Okay, and if it involves the parietal pleura, so less than 2 centimeters from carina, more than 2 centimeters from carina, and in the parietal pleura, this is stage 2. If it is less than 2 centimeters from carina and it is in the visceral pleura, this is stage T3. This is about T staging, and then we have the M stage. There is M0 when you do all the investigations and there is no nodal involvement of the hilum. We look for the hilum. If there are no hilar lymph nodes, it is N0. If there is, there is one more thing here. Collapse. If there is lobar collapse. What is lobar collapse? One lobe is collapsed. One of the lobe which is affected. If that is collapsed, we call it stage 2 disease. If the whole lung is collapsed, that is T3. So you have to not only see the size, distance from carina, involvement of the pleura, as well as the status of the lobe, if the of the lung. If the only the affected lobe is collapsed, that is T2. If the affected lung is collapsed, that is straightforward T3. Now, nodal, I said you, what is N0? N0 is when there is no nodal involvement. And one is when there is hilar lymph node involvement with no mediastinal or other sided lymph node involvement. What is N2? N2 is when there is mediastinal or subcranial. If this is the carina, you can see the carina here. If the lymph nodes around the carina, these are involved, this is N2. If the mediastinal lymph nodes are involved, this is N2. But if just the hilar, the hilar lymph node, if these lymph nodes are involved, this is N1. If the lymph nodes are reaching the subcarinal region, lymph nodes of this area are involved, these lymph nodes, we call it N2. If the lymph nodes on the other side, lymph nodes of the other sides are involved, contralateral lymph node enlargement, we call it N3. So we have N1, N0, N1, N2, N3. N1 is hilar, N2 is mediastinal or subcarinal lymph nodes, and N3 when the opposite side contralateral lymph nodes are involved. Now we stage it according to the T and M. Last is M. We said M is stage 4, so we will leave stage 4 as such. A T1A, a T1B, and a T2A with no lymph nodes is called a stage 1 disease. What is a stage 1 disease? Further divided, it is further divided, but for your easiness, you can make it like this. Any tumor up to 5 centimeters in size, but no nodal involvement, we call it stage 1 disease. Now we have further divided into stage 1A and stage 1B, but this is for stage 1A, sorry, stage 1A. Okay, now When the tumor size is increased, it is more than call it 5 centimeter. Okay, any tumor up to 5 centimeter is stage 1, and out of this, if there is size up to 3, it is a stage 1A, and if it is more than 3, it is stage 1B. Okay, now the tumor that are more after that, they are tagged as stage 2. Any tumor more than 5 centimeter in size, any tumor having N1 node with size maximum up to 5 centimeter, they are labeled as stage 2. Now, any tumor more than stage 2B, stage T2B, and 3, more than 5 centimeter with no involvement of the mediastinum except for mediastinum, they are in stage 2. And if N1, again in stage 2. All the N1 are in stage 2 except for T3 and T4. These all are stage 2. You can take it like this. These all are stage 2. Now, when the things go to the T3, this is again divided into A and B. What is 2A? T2B with single lymph node involvement. We call them 2A. But T3 without the single lymph node involvement is 2B. Okay, and after that we have this stage 3A without the lymph node involvement. We have the stage 3A. 3A, sorry. Even with first lymph node we have 3A. So straightforward T4 without node involvement or just hilar lymph node involvement is 3A. T3 with hilar lymph node involvement again is 3A. And then whole of your lesions that have involvement of the N2, they are also regarded in 3, but we divide them into 3A or 3B. Okay, T4 is T4 is stage 3. Straightforward from the very first instance, if you have a patient presenting to you with a lung lesion that is extending into the mediastinum, it is from the very beginning in stage 3. And depends on the nodal status, we can divide them into 3A or 3B. Now, the last one is N3. Now, these two stages of mediastinal involvement, no nodal involvement or just the hilar, they are 3A. And if it is higher, we label them 3B. If the patient is having a lesion with involvement of the mediastinal or the subcarinal lymph nodes, then we label them directly into stage 3, and it is called stage 3A. For whole of the N2, it is stage 3A for whole of it, except for the size of the lesion if it is approaching or if it is involving the mediastinum. The whole of the patient with nodal involvement of mediastinum or subcarina, we label them as N2, stage N2. We label them as stage 3A. And if the patient is having involvement of the contralateral lymph nodes, the lymph nodes of the other side, they are affected, then we label all of them as 3B. They all are 3B. Now, if you if you see it, only this part, 1A and 1B, they are curable with a good prognosis. The rest, other stages, they have their own modalities available, but the prognosis are not very good. For the two, I will tell you what we do. Simply speaking, for this stage 1, we offer surgery, and if needed, we offer radiotherapy. Okay, depend on the type of the tumor. Squamous cell carcinomas, they are more responding. If they are central, they are more responding to chemotherapy. So radiotherapy. So we can offer radiotherapy, but treatment of choice here is surgery. In stage 2, we offer surgery, but the prognosis is not depending on the patient's response. Plus, we have to go for adjuvant therapy, adjuvant chemotherapy. Then we have stage 3. Stage 3 is higher. Higher means it has involved the mediastinum, and it has not, if not involved, not reached the mediastinum, it has involved the mediastinal lymph nodes. So what we have to do in that case, if the mediastinum is involved, usually we don't have anything much to offer to the patient except for the therapies like chemotherapy you can offer, or you can offer radiotherapy. Prognosis is not very good. And in stage 4, we just have chemotherapy or targeted therapy if you have some specific cell type, which can be given some hormonal therapy or some specific cell killer therapy. You can offer that to the patient. So it is targeted. But keep it in mind that stage 4, when there is metastasis, we don't have much to offer to the patient. The only important thing is you have to offer curative surgery to level 1. So you have to be very careful while you are identifying the patient. If the patient is in stage 1, there is no nodal involvement, and there is size up to 5 centimeter. 5 centimeter was the limit for the stage 1B even. So if the patient is having a size up to 5 centimeter, and if the patient is having no involvement of the lymph node, we can offer him surgery. And surgery, we have different options, but the best of them is lobectomy. You can remove the whole lobe. It will clear the margins, as well as it will clear the chances of the satellite lesions in the vicinity. So this was the TNM staging, and out of all these options that we have, we can offer wedge resection, segmental resection, lobectomy, and pneumonectomy. The best is lobectomy. You can remove the whole lobe from there, and that is curable. Okay, you have to completely resect the primary tumor and the intrapulmonary lymphatics. The intrapulmonary lymphatics, they are within the lung parenchyma or along the bronchioles, the smaller bronchioles. They have to be removed along with the tumor. That's why we say the best is remove the whole lobe. Lobectomy is the procedure of choice in these tumors. And while you are doing it intraoperatively, you will look for the involvement of the lymph nodes there, and you will restage the patient, because sometime while we are doing CT scanning or other staging, the stage we do through the investigations is different than the stage we do through the histopathology, because the histopathology is more accurate, and your patient's survival or the prognosis depends on the intraoperative staging now. Okay, now it is important. What are the contraindication to the surgical resection? Sometime we even plan for the surgery, but there are some things that say us not to operate the patient, because there are contraindications. Like if the patient is having distant metastasis to areas other than the chest, or metastasis to the other lung. In both the cases, it is contraindicated to the surgery. If the patient is having invasion of the central mediastinal structure, the invasion of the pericardium, invasion of the main vessels there. So if there is involvement of the central mediastinal structure, that is a contraindication. Then pleural mets or the malignant pleural effusion, that is included in stage 4, and it is a contraindication to surgical resection. Okay, so for stage 1 and 2, surgery is the most effective treatment, and radiotherapy, if the patient is inoperable, can offer it. And inoperable means the tumor is resectable, but the patient is not in a state to be operated. Patient is old, patient is having some inoperable state, like cardiac problem or some other organ failure. You cannot operate the patient, so you can offer radiotherapy also, but the most effective treatment is lobectomy. And for selected patients in stage 3-4, you can go for induction therapy, the chemotherapy, or you can go for surgery and chemotherapy depending on the patient's presentation. And in metastatic stage 4 disease, usually we give only the palliative surgery. Palliative treatment. Okay, follow-up is very important. For 2 years, every 3 months, patient should be investigated, CT scan should be done. And after 2 years, every 6 months for the next 3 years. Follow-up is very important because these have very high chances of recurrence, and usually the recurrence occurs in the first 2 to 3 years. That's why we do it very frequently in the first 2 to 3 years, and then after 5 years you can stop doing follow-up so frequently. Local recurrence can be in the same lung or in the same surgical margin, and the regional recurrence can be in the mediastinal lymph nodes, or systemic recurrence can be anywhere outside the thorax, in the contralateral lung or the area outside the thorax, like brain, liver, or other areas, bone. Okay, this is the survival rate in stage 1. The survival rate is about 55 to 75%, and less than 50 for stage 2. And after that, in stage 3, the chances are very the survival or the prognosis is very low or very less. And the patients, they are, if you are having a patient and you are suspecting that patient is very well and I can resect it, still then, as the chances of survival are low, we usually give palliative treatment. We don't go for extensive surgeries. Overall, the survival rate is 13% because most of the patient who come to us, they are symptomatic and they have a stage of about 3-4. So usually the overall survival rate is 13%, 13% 5-year survival rate in these patients. Okay, small cell lung carcinoma, the most common is the oral cancer, and it is capable of expressing paraneoplastic syndrome because of the release of ACTH or ADH hormones. It is an aggressive tumor and it metastasizes early, strongly associated with smoking. Symptoms can be because of the local tumor, they can be because of the metastasis in the lymph nodes, or they can be because of the distant metastasis. Patients usually present with paraneoplastic syndrome, and there may be anorexia, cachexia, and low-grade pyrexia. So this is an overall view of what we have to do if we see such a patient presenting to us. We have to go for a history and examination and do all the routine investigations and imaging of the patient with chest X-ray, CT scan, CT abdomen to rule out the mets in the liver, PET scan, and MRI of the brain. And the staging of small cell lung carcinoma is different from the rest of the carcinomas. For the rest of the carcinoma, we have the TNM staging, but for small cell lung carcinoma, we have limited, specific staging that is according to the disease progression. If the disease or if the nodule or the tumor is in one part of the thorax, in just one lung, we call it limited disease. If it is spread to the other side, we call it extensive disease. And if it is, and this spread means hemithorax. Hemithorax means it is involving the side of the mediastinum, it is involving the side of the pleura or the chest cage, whatever it is, limited or extensive disease, if it is involving one hemithorax or the other. There is another variety that is called very limited disease. If the disease or if the tumor is just a nodule that has not involved the other areas of the thoracic cage or other area of the hemithorax. like the mediastinum or the hilar lymph node. If it has not involved any of these, we call it very limited disease. But the rest, if it is limited to one side, that is limited disease. If it is on both sides, we call it extensive disease. So for a very limited disease, we can offer surgery and survival rate is good. For limited disease and extensive disease, we have to go for chemotherapy. And in extensive disease, the 5-year survival rate is less than 5% in symptomatic patient. And we use radiotherapy for palliation. Like in brain mets or in bone mets, you can offer palliative therapy. And in limited disease, you have to go for a chemotherapy. And survival rate is about 20%. So out of these 3 varieties, the very limited disease, which is just localized to the lung, it can be cured with the surgery, and the survival rate is good. Okay, now a few slides about the lung, other inflammatory conditions of the lung. Lung abscess is, it could be because of many reasons. It could be because of aspiration. It could be because of aspiration pneumonia, necrotizing pneumonia. It could be because of infection in some other part of the body, and by the blood-borne blood route, it can reach into the lung and cause infection. It could be because of some pre-existing lung disease, and it could be because of immune deficiency. Okay, usually the presentation is of a cavitating lesion, and if you see the cavity very carefully, you can see the air fluid level inside. This air fluid level tells you the level of the pus. And you have taken this in medicine also, so I'm not going into the detail of it because it is managed by the medicine people unless until there is associated empyema thoracis, and we treat it surgically. Thoracic empyema or empyema thoracis is when the pus moves from that specific localized cavity into the pleural membrane, into the pleural space, and it accumulates there, and it causes difficulty in breathing, and it causes pressure on the lung. The lung is unable to expand, and patient presents to you with breathing difficulties and other respiratory compromised symptoms. How we have to manage this empyema thoracis? Usually, if the patient presents to you earlier, within 1 to 2 weeks, we can offer drainage. We can drain it, we can pass a chest tube, and we can drain this empyema thoracis. Early drainage will not let the inflammation to spread on the pleural membrane, and the pleural membrane will be soft. But as the process continues, the pleura become thick, and even if you have drained all the pus, you will see that patient is unable to breathe normally, because that lung pleura or the pleural covering over the lung has become thick, and it doesn't let the lung to expand. So this is the organized phase. So there are an in-between phase also, but usually it starts from an exudative phase in which there is just the pus, and there's an organized phase in which the pleura has become so much thick that it is not letting the lung to collapse, even if there is no pus in the chest cavity now. So in between phase is the fibrinopurulent phase, in which the pus, it has become very thick. It is difficult to be removed from that area, and the peel over the lung is getting a bit firmer. So what we offer in the stage 1, when the pus is, when there is only the pus and it is not very thick, we can offer the drainage. And after that, we can go for in the phase when the pus is very thick and it is difficult to be removed via the chest tube. We can offer a open window thoracotomy. What is an open window thoracostomy? It is not thoracotomy, it is thoracostomy. What is it? I told you yesterday that if we cannot clean the whole pleural membrane, we cut a piece of the rib and we make a window, and through that window we wash the whole pleural cavity. That is called an open window thoracostomy. We don't we have put the chest tube before, but that chest tube is not working. Pus is thick and it is not coming out easily. So what we can do, or there are loculations, there are septas inside and the pus is localized in different parts where your chest tube cannot reach. What you will do, you will cut a rib, a part of the rib, and you will wash it thoroughly with saline, with irrigant fluid repeatedly, and you will take out all the pus. This is called open window thoracostomy. In case you have drained all the pus, you have cleaned everything, the chest apparently is clear, but the patient's lung is collapsed. It is not expanding with the breathing, and inside there is no fibrosis. Lung is not fibrosed, lung is okay, but the pleura is so much thick that it is not letting the lung to become expand again. So what you will do, what you will offer here is you do decortication. We remove the pleura from the lung surface. We remove that thick pleura from the surface of the lung so that the lung is out of, just like sclerotomy we explained. What is a sclerotomy? You are having a thick scar outside that is not letting the normal flow of the things or normal breathing. So what we do here is we cut open the peel or the thick pleura and we peel it off, just like you're taking the peel of a orange. You remove the whole peel and the lung again starts becoming expand. So we can offer this also. It's called decortication. And there are other maneuvers also. Don't go into the detail of it, but just remember this thing, that in earlier phase we do chest intubation. If patient is not settling because the pus is too thick, we go for an open window thoracostomy. If still the pus is removed but there is no expansion of the lung, we go for decortication. So this is all for today's lecture about the lung diseases. You can take a 10 minutes break and then we will start the other lecture. We have 4 lectures today, okay? I have shared one Word file. Just go through it and every one of you should attempt the questions. For tomorrow, I will ask any of the students to answer the specific questions. So go through all these because these all questions are from your lectures and the yesterday's, from the lectures, not from the yesterday's activity. So it will not be difficult for you. Everyone should prepare it. I will ask anyone to answer, okay? Okay. Want to take the break or should we start the other one? Want to take the break? Class is sleeping. Hazim, I will check for your name in the registrar. The names that were mentioned, they all are added. I will check your status. I don't know about it. But if you are attending the lecture, you will not have any problem. I will mark myself manually. Should I continue the lecture or should do you want a break?
Yes, doctor, I can hear you.
Everyone is here? Okay. Covered the lung. Now I'll go for the mediastinal tumor, mediastinal lesions, because they both are related. Just a minute, I will share my screen. Starting it. Okay, we'll discuss now the mediastinal diseases or the disease of the mediastinum. As I already told you that you already know that mediastinum is the region of the chest between the pleural cavities that contain the heart and the other viscera, except the lungs. Heart, the major vessels, some glands, gland. You can imagine the thyroid gland coming down, or the thymus gland, and are on the back side of the heart. So these all are the contents of the mediastinum, and its boundaries are on the lateral side. If you can imagine, on the lateral side are the lung. So lung is surrounded by the parietal pleura. So on the lateral there is parietal pleura. In the front there is the sternum. On the back there is the vertebral column and the vertebral gutters. And superiorly we have the thoracic inlet, from where all the things are entering into the thorax. And inferiorly there is the diaphragm. These are the rough boundaries of the. Now one by one we'll discuss the different parts of the mediastinum. The first is the anterior mediastinum. It is a very small area that is in front of the heart, and it is in front of the heart as well as in front of the major vessels of the heart. So it is bounded by the sternum, the first rib, the imaginary line that is in front of the heart, and the bronchocephalic vessels, or the vessels that are coming out of the heart. And contents, the contents here are important. These are the thymus gland, the substernal extension of the thyroid gland, and some lymphatic tissue. So here there are no vessels, there are no nerves, there are just some glands and some lymphatic tissue. This is the anterior mediastinum. This is its boundary. The green one is the anterior mediastinum, if you can see. Then we have medial mediastinum. That is actually the heart itself, and it extends from the lower edge of the sternum along the diaphragm, and then separated along the posterior heart border and the posterior wall of the trachea. It contains the heart, the pericardium, the aortic arch that is coming out of the upper part, and its major branches. It also includes the innominate veins and the superior vena cava that is entering into the heart. The pulmonary arteries and the hyla and the trachea, that is the lower part of the trachea, and the lymph nodes which are surrounding this region, the mediastinal group of the mediastinal lymph nodes. And here also the phrenic nerve and the upper vagus nerve are also passing from the lateral sides. So they're also included in the middle mediastinum. This red one was the middle mediastinum, and then is the posterior mediastinum, the part of the mediastinum that is behind the heart and behind the trachea, and the what is it? What is its extension? It is extended from the diaphragm till the first rib, and it contains esophagus, which is coming down from the thoracic, from the neck region, and passes behind the heart. So there is esophagus, there is descending aorta. Arch of aorta is in the middle mediastinum, but the descending aorta is in the first part of the aorta is in the middle mediastinum, and the descending aorta is in the posterior mediastinum. And we have the azygous and the hemiazygous vein, which are coming from the right and the left side, and they go behind the heart. And then we have the paravertebral lymph nodes, which are around the vertebral column. We have the thoracic duct and the lower portion of the vagus nerve and the sympathetic chain. Now keep it in mind, the vagus nerve and the sympathetic chain, they are in the posterior mediastinum, and these are the sites for the neurogenic tumors. So usually the neurogenic tumors, they arise from the posterior mediastinum. So this is again just the revision of the anatomy. We have anterior mediastinum anteriorly, and what are the contents? They are the glands or the lymph nodes. So usually the problems of the thymus, problems of the enlarged thyroid tissue, or a malignancy of the thyroid tissue that is extended down, they can have problems here and compression in this region. Then we have posterior mediastinum behind the heart, and it contains esophagus, the hemizygous and the azygous vein, the nerves, and the sympathetic plexuses, and the descending aorta. Then we have inferior mediastinum, and out of it above we have a superior mediastinum, which is behind the manubrium. And this is we discussed it with one group yesterday. This manubrium and the body of the sternum, the lower end of the manubrium is curved forward, and this is at the level of second rib. The second rib is attached here with the manubriosternal area. the lower end of the manubrium. So this is also one of the way to identify the rib counting. You can start rib counting by feeling the angle of Louis, the most prominent mark on the sternum, the most prominent ridge on your sternum, and then the rib that is attached to its lateral edge, that is called the second rib. So you can count the ribs through this also. Okay, superior mediastinum is bounded anteriorly by the manubriosternal joint and posteriorly by the inferior edge of the T4 body. And contents are again the vessels that are coming out of the heart and going to the upper periphery. And there may be the extensions of the lymph nodes, extension of the glands down into the superior mediastinum to the anterior mediastinum, as well as the lymph nodes. So it contains the vessels and the nerves and all the glands that are coming and extending from the above to the down. And it is not a very big space because on the both sides are the apices of the lung, and they compress this area. It is not a very big space, so usually the masses here, they are presented as widening of the mediastinum. This is a very common presentation. They will be widening of the mediastinum when we do the X-ray. The asymptomatic masses, which do not have any symptom, they are about 50% of cases just like this, and they are usually benign. There is incidental discovery when we do a routine X-ray. There is widening of the mediastinum, and we find some asymptomatic problem there. And in the early phase, they are silent, they don't have any symptom, but later, because of the increase in size, they may cause pressure symptoms. And if these are with symptoms, you have to be careful about the malignant, because usually malignant tumors in this region, they present with symptomatic problems. Okay, what are the symptoms? Symptoms can be compression on the adjacent areas, tissues, like it can compress the lung, it can compress the heart, it can compress the major vessels there. So it can present with compression of these tissues. It could be chest pain because of the traction of the mass, or because of the bone erosion in the front or the back, or because of the tissue invasion. Cough can be one of the important presentation, because it is causing compression of the trachea or the bronchi, or itself it can enter into any of these airway, and it can cause the symptoms of respiratory problem, cough or hemoptysis. Then if it is affecting or involving or irritating the pleural space, it can present as pleural effusion. Dysphagia, because in the posterior mediastinum we have esophagus that is going down from neck to the abdomen, and invasion of that can present with as dysphagia. There can be involvement of the heart sheaths, pericarditis or pericardial tamponade can be the presentation, or when the outflow obstruction is evident, or there is outflow obstruction, you may have enlarged heart or pulmonale. Okay, what is superior vena cava syndrome? This is a common presentation of malignant lesions of the mediastinum. When the tumor is causing pressure on the upper thorax, it causes a compression of the superior vena cava that is draining into the heart, and it is coming from superior mediastinum. And what you see a patient with engorged neck veins or multiple collateral neck veins in the upper portion of the head and thorax region. And if you see the face of the patient, it is edematous and it is reddish. It's more reddish discolored because of the more blood, what you call it, engorgement of the vessels in the head and neck region. And they may have pressure symptoms. Some patient may present to you with headache. So this is all, if you can see in the lower down picture, and you can see in this picture, this is a tumor, and it is compressing the superior vena cava, and because of it, there is engorgement of the vessels above it, and the facial changes, as well as dilatation of the vein, or because venous blood has to reach heart with some means. So there may be extensive network of veins as the veins try to empty into the inferior vena cava. So you will see dilated and engorged neck veins in this region. Okay, Clinical presentation can be depends on what is the effect. It could be hoarseness, Horner syndrome, dyspnea, tachycardia, or symptoms inside of spinal cord compression. All depends on what area the pressure is being built. The area which is under more pressure, the symptoms will be according to it. There may be systemic symptoms and syndromes, less like the SVC syndrome we just read, and patient may have specific symptoms of malignancy or some non-specific symptoms. Non-specific symptoms may be fever, anorexia, or weight loss, and specific symptoms is according to the presentation, according to the location and the pressure it is causing on the specific areas. Okay, how we can investigate this area? If you are suspecting some lesion and you are dealing with such a patient, you can offer a simple chest X-ray. Simple chest X-ray can tell you there is some widening of the mediastinum or some haziness in the area of the mediastinum. And you can offer a chest X-ray, chest CT scan with contrast, and that can visualize all the detail of the tumor and its extent and the involvement of the lymph nodes. Okay. How we can take biopsies? Biopsies by FNAC, you can take it percutaneously or image guided percutaneously, or you can go for a bronchoscopy or endoscopic ultrasound. There is, just like we try to put scopes in abdomen, a laparoscopy, we can go for a thoracoscopy. The same is here, we can go for a mediastinoscopy. With a small scope, we can enter into the mediastinal region behind the sternum and we can take biopsy. But the mediastinoscopy is not a simple procedure. It is very difficult, and it is with its own moving in a very small space, and your movement is very restricted. So sometimes we go for mediastinoscopic biopsies if we have the feasibility, or we can take it through the VATS, through the video-assisted thoracoscopic. From the thoracoscope we can go, or we can take the lesions biopsy if it is within the reach of the thoracoscope. So these can be the options, and if not, if you cannot take biopsy from any of these, means you can go for thoracotomy. If you are planning for some surgery, you can go for thoracotomy and you can do X-ray biopsies of that specific lesion. Now we'll discuss one of the common problem that can present as a tumor of the mediastinal region, thymomas. Thymoma is a tumor of the thymus gland. It is the most common mediastinal tumor in adults, and it's usually present in 30 to 50 years of age, equal in frequency in male and females. Again, in 50% of the cases, these are asymptomatic. Patient does not have any symptom, and histologically, these are usually these are benign, but some are malignant also. And there is sometimes it's association with parathymic syndrome. The patient may have myasthenia gravis, and less commonly, patient may have hypogammaglobulinemia, or they may have red cell aplasia. We stage thymomas according to the we stage the malignant variety of thymoma according to the involvement or according to the invasion. If it is encapsulated, not invading the capsule, but not going across it, we call it stage 1. If it has crossed it, or it is into the fatty tissue around, it is stage 2. If it is going into the neighboring organs means some other organ is affected, like it is rising from the from the superior or the anterior mediastinum, and then it goes into the lung, or it goes into the heart, or it goes into the sternum. It is called stage 3. And if it has a dissemination to some other place, or there is pleural or pericardial effusion, this is stage 4. So for thymomas, what we can offer, we said that they are not, they are commonly benign, but the malignant variety need to be treated. And why? Because in the early stages, stage 1 or stage 2, the survival rate is very good. So we offer surgical excision till the stage 3, till there is involvement but not metastasis. So we offer surgical excisions till the stage 3. Stage 1 is good, it has good curative rate if you completely excise the lesion. Stage 2, you have to not only excise the lesion, but you also have to give radiotherapy. And in stage 3, we excise and give we give radiotherapy, but the chances of recurrence are more. So you have to be careful at the surveillance. You have to do repeated surveillance to check for the recurrence. In a stage 4 disease, when there is pleural effusion or involvement of the there are metastasis and there is involvement of the pleural, the pericardial space. If the tumor is causing pressure symptoms, you can do surgical debulking. But usually the prognosis is not very good. We can offer it, but the prognosis is not very good. Or we can say that usually the patient they don't they have a survival rate of about 25%. So you have to just offer the symptomatic treatment. If there is pressure symptom, relieve the symptoms. If needed, you can go for radio or the chemotherapy, but surgical resection is not possible here. Surgical resection means you are completely taking off the tumor and the patient is disease free for some time. Recurrence can occur, but the patient is disease free. But in stage 4, we cannot offer it. So what we do is just surgical debulking. If the tumor is too much and causing pressure on the lung or the heart, you can debulk the tumor. You can reduce the tumor, cut the extra tumor that is causing pressure. You cannot go for complete excision. So in stage 4, we are limited. Lymphoma is the second most common anterior mediastinal mass, and they can be Hodgkin or non-Hodgkin's lymphoma. What we have to do when we are seeing such a patient? We are actually only there to give a specimen for biopsy. Lymphoma is usually does not have any role of surgical treatment, but the only role of surgeon is when you are being called is you give some way or give some technique to take out the tissue for the specimen. So our only role there is to provide sufficient tissues for the diagnosis and for the staging of the disease. So we can offer a mediastinoscopy, sometimes thoracotomy and other thoracoscopy can be offered to take the biopsy. And sometimes it is through the percutaneous route, or you can say from the under the imaging guidance, we can offer the percutaneous to cut biopsy. Treatment is chemotherapy and radiotherapy. There is no role of any surgery in the lymphomas. And usually the prognosis of the tumor, it varies with the tumor's histology. Okay, and there are some germ cell tumors. These are benign or malignant. And maybe benign tumors like teratomas or the dermoid cyst. And their presentation is asymptomatic lesions that are diagnosed on extra CT scan and cause cough, dyspnea, or pain. And they may be calcified. They are well circumcised or may be calcified. And we do surgical excisions for these teratomas. When it is obvious that there is a malignant variety, usually a patient has more respiratory symptoms, and what you see is a large anterior mediastinal mass, and the tumor markers are raised. And if you offer something for it, it is radiotherapy, because these out of these for the seminomas we can offer the radiotherapy, because seminomas are radiosensitive, while the non-seminomatous germ cell tumors, they are not radiosensitive. They are it is mentioned here radiosensitive, but they are not radiosensitive. So we usually we don't offer them radiotherapy, but for the seminomas we offer radiotherapy. Okay, thyroid can come to this area because of the thyroid enlargement. The thyroid dips down into the mediastinum, into the superior as well as into the anterior mediastinum, and these are sometimes these are the part of the whole gland enlargement. Sometimes these are ectopic, a separate part of the lobule, it dips down because of the intrathoracic pressure. It starts growing downwards, and it is ectopic. Sometimes it becomes separate from the main gland. So sometimes it is attached to the main gland, and sometimes it is separated from it. Okay. Radiographically, what we see here is a mediastinal mass with superior mediastinal widening. There is tracheal deviation or the compression. And when we do the chest CT scan, we can see the whole extent and the relationship of that thyroid to the surrounding structures. And it helps us in planning of the management also. Then we have neurogenic tumors, the tumors that arise from the sympathetic ganglions or from the nerve sheaths or from the peripheral nerves. They are usually in the posterior mediastinum. As we discussed before, the neurogenic tumors are from the nerves that are present in the posterior mediastinum. So usually these tumors are seen in the posterior mediastinum. And these can be neurofibroma, schwannomas, or malignant tumors of the nerve sheath origin. We have benign cysts also in this place, but they are not very much. 20% of the total mediastinal masses, they can be benign cysts, and they are asymptomatic. This could be bronchogenic cysts, pericardial cysts, enteric cysts, or thymic cysts. Pericardial cyst is more common in the right cardiophrenic angle, and patients are asymptomatic. Rarely when it is causing compression symptoms, it needed to be removed because of its presentation. Bronchogenic cyst, which are arising from the respiratory epithelium, they are they are the most common of these mediastinal cysts because they're arising from the bronchioles and the main bronchial tree. They may contain cartilages or mucus, and they may become infected. The problem is when they become infected, they become symptomatic. Patient may have wheezing, dyspnea, and recurrent pulmonary infections. Okay, one more reason for the mediastinal enlargement is aortic aneurysm. And you have discussed it in medicine also, so I'm not going into the detail of it. Paratracheal lymphadenopathy, again, it is one of the cause. So all these are the causes. Starting from the very beginning, we are not just discussing the things that are causing space occupying problems in the mediastinum. So we have paratracheal lymphadenopathy, and finally, if you are having a paramediastinal or mediastinal lymphadenopathy, you have to rule out what is the drainage area from where these have been enlarged, maybe some lesion in the lung, or maybe some lesion in the other structures in the vicinity, and you have to localize the disease and identify the underlying problem. Just finding some big mass of lymph nodes in the mediastinum is not your finding. You have to look for from where these lymph nodes have come from, and you have to identify the primary. And treatment is according to the primary. Whatever is the primary, you have to stage the disease or stage that lesion, and you have to treat it. If it is infectious etiology, you can offer the proper antibiotic therapy. Okay, this is all for mediastinal diseases. To be aware of the presentations, as well as what is the presentation of a lymphoma and thymoma. The rest are minor things, and we don't want you to be more familiar with this, but you should know what is a thymoma, what is a lymphoma, and how do they present. And with these tumors, there is a superior vena cava syndrome also. So sometimes patient's presentation will be with the superior vena cava obstruction. So when you are having a patient with a superior vena cava obstruction, keep it in mind, it can be a mediastinal tumor that is causing pressure on the superior vena cava, and that is presenting to you with this problem. And you have to investigate you have to take the CT scan of the thoracic region to check for the mediastinum. Okay, any question from this lecture? Any question? You want the break, or should we start the lecture? We have still 2 lectures, esophageal diseases and pediatric emergencies. Want break or should I start the 3rd lecture? Sorry. Or are you all sleeping? Okay, start it. Okay, now the lecture we will start will be on esophagus. As we have discussed, what is the most common presentation of esophageal disorders? What is the most common presentation for any benign or malignant problem? What is the most common presentation of esophageal problems?
Dysphagia.
Dysphagia. So whenever you come across a patient of dysphagia, you have to keep the whole set of differential in mind, and you have to ask questions in the history to rule out all of those causes. Patient presents in dysphagia, how, for how long, what are the associated symptoms, what are the what is the nature of that dysphagia, is it with solid or liquid, gradual onset, sudden onset, its location of the problem where the patient is feeling that I feel that my food is stuck in this area, or which where he or she points. You have to note it down. Then your differentials will be in your mind, and the 3rd step of your questions will be to rule out the differentials one by one. It could be a dysphagia because of some psychological problem, so you have to ask about it. Sometimes we have seen cases, patient having dysphagia and investigating from various places, and when she presented, that was just a status of globus hystericus. Globus hystericus is a situation in which patient hysterically feels that there is some dysphagia. There is no other symptom, there is no organic lesion, and the problem is some stress or some very serious condition the patient suffered from, very serious mental stress the patient suffered from. And I remember one patient, her mother died few months back, and for the last 3 months she was having the symptoms. When she was going to various doctors and she was having different investigations, but she was not being taken a complete history. So when you are taking the history, keep these things in mind, that you have to identify, because this is the only coin symptom in these problems. The coin symptom will tell you that what is the problem. Sometimes patient presents to you, and you have to inquire the history. History means what happened to the patient in the previous years. Maybe there is some corrosive intake history 2-3 years back, and now the patient is developing the symptom because of the strictures developing inside. So you have to be careful about all the differentials that can cause esophageal problems, and you have to ask questions in your history to dig out what is the exact situation here. Now, just a minute, I will start sharing. Can you see the screen? Can you all see the screen? Okay. So if you talk about the surgical anatomy of the esophagus, Esophagus is a muscular structure, muscular tube that is extending from the oral cavity till the stomach. And while its passage down from the oral cavity to the stomach, it is passing behind the main airways. It is behind the trachea and the neck. Then it is behind the main heart vessels and behind the heart, and it reaches the stomach by being in the posterior mediastinum. And some part of the esophagus is still below the mediastinum, and then it enters into the into the stomach. So it has three parts: the part that is in the neck, the part that is in the thoracic region, and the part is that is in the abdominal region. So we have the cervical part, the thoracic part, and the abdominal part of the esophagus. So esophageal diseases can be benign, or this can be malignant. Benign diseases can be because of the motility disorders, because of diverticula, because of some benign tumors that can be the cause of dysphagia. Then it can be the GERD or hiatus hernia problem, and esophageal perforation because of different causes, or it could be caustic injury causing strictures and obstruction to the flow of the esophagus. The gastroesophageal reflux disease, the lower esophageal sphincter and the hiatus, they both have a role in preventing the reflux of the stomach contents into the esophagus. But when the lower esophageal sphincter is relaxed, or it does not have the full power to stop reflux, it let the gastric contents go into the esophagus, and patient develops the gastroesophageal reflux disease or the GERD. So it is actually the incompetence of the lower esophageal sphincter that is the reason for the GERD. And as you can see here, usually the sphincter is closed when the patient is relaxed. But if the sphincter is not closed and it is incompetent, what will happen? The sphincter will allow the stomach contents to enter into the esophagus, and it will cause the signs and symptoms of GERD. Sometimes it is not just GERD alone. Sometimes there is a hiatal hernia also, and that hiatal hernia is the responsible feature, responsible element for the GERD. What is a hiatal hernia? The esophageal, the diaphragmatic hiatus, from where the esophagus enters into the abdomen, it becomes wide. It becomes wide enough that it causes the stomach to move up towards the thoracic cage, or sometimes the stomach, just like intussusception, it is separately entering into the thoracic cavity. So we have different types of hiatal hernia. Sometimes it just slides up, and sometimes it is sliding, and sometimes it is rolling up. So we have different varieties depending on the presentation. And sometimes these hernias are not only causing the stomach to herniate, but some of the structures that are in the excuse me. Okay, sorry. This video. Okay. So sometimes there is a sliding hernia, in which the stomach is sliding separately from the esophagus into the thoracic cage. And sometimes this hernia is not alone. Some gut loops can also join in, and they can also be found in the mediastinal region, in the posterior mediastinum. So GERD is associated with hernias, and hernias can be the sliding hiatal hernias or the rolling hiatal hernias. Okay, what is it actually? It is the symptoms of reflux or mucosal damage because of the abnormal reflux of the contents into the esophagus. Patient, they have the chronic problems, or the problems may be relapsing again and again. The patient has a problem of acidity or other reflux symptoms, and these settles with the treatment, and then they come again. So they may be relapsing, or they may be chronic. Continuously the patient have these symptoms, and there are many complications that you can have in these patients if the patient does not have the typical symptoms. There is one condition called Barrett esophagus. We'll discuss it later. That is also one of the complications of GERD. Epidemiologically, this is very common in US population, and patient with heartburns, they should be investigated for this. And the typical presentation is patient presenting to you with dyspepsia, with heartburn, and the symptoms are related to the esophageal hyperacidity. But there may be atypical presentations which are extraesophageal, or there may be complicated reflux disease. Okay. Classically, the symptoms are substernal burning, regurgitation, postprandial pain, pain after eating of anything. Patient develops severe acidity in the thoracic region. And these symptoms, they are aggravated by change of the position. Patient is in the standing position, may not get any pain, but when he lies down, the symptoms are aggravated. And these symptoms, they are relieved by antacids. Okay, the extraesophageal manifestations, which these are the typical symptoms, the previous are the typical symptoms. Now these are the symptoms that are symptoms of GERD, but they are not related to the esophagus. So patient may have asthma because of the asthma and the respiratory complaints because of the aspiration of the contents while sleeping into the lung airways or into the airways. There may be chronic bronchitis, or there may be pulmonary fibrosis because of the repeated reflux activities. There may be involvement of the other passages, air passages areas, like there may be laryngitis, pharyngitis. Patient may have chronic cough, globus sensation. Because of this continuous problem, patient may have a globus sensation that there is something that is causing obstruction. Patient may have dysphonia, patient may have hoarseness of voice, sinusitis, or a subglottic stenosis, and it can be a precursor of laryngeal cancer. Others can be chest pain or erosion of the teeth. Diagnostic test for GERD is barium swallow. You can go for endoscopy, ambulatory pH monitoring, and esophageal manometry. Now, tell me, out of these, which should be the best in identifying or differentiating it from the other causes? What is the most likely to be to differentiate it from the other causes of dysphagia? Barium swallow, endoscopy, ambulatory pH monitoring, or manometry? Which of these is the, you can say, classically tell you that this is a GERD? Any student? What is the problem in the GERD? What is the problem in the GERD? In the GERD, the main problem is acid reflux. So ambulatory pH monitoring can give you an accurate idea of the problem, and you can identify it by monitoring the pH in different position and different periods. Barium swallow has role in identifying the hiatus hernias. When you're doing the barium swallow, and there is associated hiatus hernia, which is associated with GERD. Hiatus hernia is actually causing the stomach to move from the esophagus, from the abdomen into the thoracic region, and there is no lower esophageal sphincter now, and that incompetence of the esophageal sphincter is now the reason for the GERD. So barium swallow will help you in identifying the hiatal hernia. And endoscopy, we do it to rule out if there is any associated Barrett's esophagus or any change in the mucosa or any ulceration of the esophageal mucosa. Manometry has no role usually here because or we can check the competency of the lower esophageal sphincter, but it is not needed usually because of the other things telling you the diagnosis. So manometry is the last, or you can say the least suitable here. But usually we go for ambulatory pH monitoring, or we can go for a barium swallow to check out the hiatus hernia, and endoscopy can give you the biopsy if you are suspecting any associated ulcer or any associated lesion or the Barrett's esophagus. Now, now the complicated GERD, it can present is dysphagia, which is difficulty in swallowing, and patient says that food stucks up or hangs up in some part of the esophagus, or there may be odynophagia. Odynophagia is painful swallowing. Patient, when swallow, patient experiences pain in the retrosternal area. So there may be odynophagia, and patient may present to you with hematomesis. Treatment for GERD, as GERD is not, if GERD is not complicated with other problems like Barrett's esophagus, or with other conditions like strictures or hiatal hernia, treatment is lifestyle modification. We can offer acid suppression therapy. The acid level is controlled, and the acid reflux symptoms will be minimized. We can offer anti-reflux surgery if the patient is associated, patient is having a hiatal hernia, or patient is having some element of herniation of the stomach into the thoracic cavity. And this can be endoscopic. We can go for laparoscopy, and laparoscopically we can offer the fundoplication or the Nissen or the whole fundoplication. Okay, so lifestyle modification is ask the patient to elevate the bed, head end of the bed, and before bedtime, he should avoid eating at least about 2 to 3 hours. And if the patient is overweight, he should be given the weight loss program. Smoking should be avoided, and patient should be advised to modify the diet intake. He should take frequent but smaller meals. If he is taking one big meal 3 times a day, he can make it like small meals 6 to 8 times a day. He can make them small but frequent, and he should avoid fatty food. He should avoid the other stimulants like chocolate, alcohol, these Pepsi and the other beverages, coffees and teas, and we can give over-the-counter medications for the treatment of the dyspepsia. We can offer them. They can take Zantac or the PPIs, which are available over the counter. Okay, specific if the patient is having severe symptoms and not settling with the lifestyle modification, you can offer specific therapy. You can offer them H receptor antagonist or proton pump inhibitors depending on the patient's presentation. Okay, when you should plan for surgery, if the patient is having intractable disease, the disease is not settling. If the patient, these are for a patient with hiatus hernia, because usually we don't treat these patients very frequently. If the patient is having a big hiatus hernia, or the patient is having severe symptoms, then we offer the procedures to tighten the lower esophageal sphincter a bit. The tightening of the lower esophageal sphincter will cause the GERD symptom to become lower. So if it is intractable symptom, if it is patient's desire, if there are complications like Barrett's esophagus has been developed, or there is severe esophagitis, or there are atypical symptoms, and 24-hour pH ambulatory pH monitoring is documented, then you have to go for surgery. Surgery we do is Gastroesophageal junction heating by the radiofrequency method. You can cause the it causes the lower esophageal sphincter to contract, and it becomes slightly shrink in size, and it becomes its function becomes active. We can go for endoscopic plication. We call it Nissan fundoplication. This fundoplication is done in a way that we suture the diaphragm flap to the around the curve of the esophagus, and we try to narrow down the entry of the esophagus into the thorax, esophagus from the thorax into the abdomen. So when we narrow down that opening of the diaphragm, it also reduces the symptoms of the GERD. This is the fundoplication. You can see you can cause the, you can make the flap of the diaphragm and you can close it. You have to make sure that your narrowing down of the sphincter is not so much that within a few period of time patient presents to you with symptoms of dysphagia or obstruction to the lower esophageal sphincter. So we don't want obstruction. We want it become a bit competent. So you have to be very careful while you are doing these surgeries. Sometimes we just put endostim over the lower esophageal sphincter, and it causes some tightening of it with the with its fibrosis and fibrotic action. So now we are going on to the other condition, that is achalasia. What is achalasia? It is an problem. It is an uncommon disease, and there is degeneration of the myenteric nerves that innervate the lower esophageal sphincter and the esophageal body. It could be primary or secondary. The cause can be autoimmune, viral, or genetic in primary conditions, or it could be secondary, in which there is infection by a parasite, Trypanosoma cruzi, which is which infect this area, and it causes secondary achalasia because of the destruction of the nerves that are responsible for the esophageal motility. The most concerning secondary etiology of this is cancer, and it can present as achalasia as it is causing mechanical obstruction of the gastroesophageal junction. What is happening here? The area of the lower esophageal sphincter is very tight, and if you see, it is like a rat tail. The same is the presentation of this problem in the in the barium solo. When we do the barium solo, you can see. I did not put the picture, I think. Sorry, it is here. You can see that there is a widened esophagus with a small tail-like thing. It is called a rat tail appearance or a bird beak appearance. Both names are given to it, a rat tail appearance or a bird beak's appearance. It is gradual. You can see it is gradual, and then it becomes thin like a bird's beak or thin like a rat tail. This is the same appearance that you will see in the barium solo of the patient. So there is severe spasm of this lower esophageal sphincter area, as well as the lower esophagus, and this is what you say. The muscles that are in this area, they are thinned out. They are not thick, they are thinned out actually. Now, clinical feature is it has two peak ages in the young age, at the age of 20s or at the age of 60s. Male to female distribution is equal. The common presentation is dysphagia, and to differentiate it from the malignancy, the patient presents to you with dysphagia earlier to liquids than to solid. Now think yourself that you are having a patient with a tumor. What is that tumor causing? It is gradually causing the esophagus to become constricted. So what will happen? when the patient comes to you, patient says that I had this problem for the last 6 months, and earlier I could take everything, but there was some difficulty. Then I started feeling that I cannot take the solid things, but I could take the liquids. And with the passage of time, the liquid intake was also affected. So the patient has dysphagia for solids earlier and then the liquids. But what happens in eclasia? In eclasia, the patient is having problem with liquid intake, because when the liquid you take liquid has less weight, and they are distributed. So what happens that it does not cause much pressure on the esophageal sphincter, and it becomes or you can say it distributes to the surroundings of that widened area. But solids have weight, and they exert pressure in the central part, and they are easily to pass through the narrowed area. So patient has dysphagia for liquids in the eclasia, initially for liquids and then for solids also, because when it is too severe, it does not let even the solids to pass. So they have dysphagia for liquids. But in malignancies, patients have dysphagia for solids initially, and then when the disease progresses, they have dysphagia for liquids also. Clinical features can be regurgitation. What is regurgitation? Patient is sleeping, and he feels that the whole, without any pressure, without any coughing or anything, the things are coming in his mouth. There is no pressure, there is nothing. This is regurgitation. One is reflux, that that there is things are coming with pressure and you have to spit it out, just like vomiting. But regurgitation is the things are coming in your mouth without any without any pressure or without any problem. You're just sitting and you feel that there is water in your mouth that's coming from your stomach. Okay, this is very common in these patients also, because all the things are stored in the esophagus. So regurgitation is the second most common symptom, and it's in 60% of the patient, and it's while the patient sleeps in the night time, this nocturnal regurgitation can be complicated with aspiration pneumonia, respiration problems. Okay, chest pain is also one of the features. It's about 20 to 60% of patient presents with chest pain, and heartburn. 30% of the patient presents with heartburn. And this may be related to direct irritation of the esophageal lining by retained content, or the acidic byproducts of the bacterial metabolism of the retained food. Diagnosis. How to diagnose it? The first thing is when we do chest X-ray, we can have an air fluid level in the mediastinal region, because the solids, the liquid portion of the food is in the lower part of the esophagus, in the thoracic region, and above is the air. So we have a plain, or you can say a linear air fluid level you can see in that region. Then when we offer the barium solo, you can have the typical dilated esophagus with a rat tail or the bird beak appearance, and it's a hallmark, or you can say classic finding. When we do endoscopy, it does not have much benefit here, because when you do the endoscopy, there is all retained food inside, and it's full of the things. The first thing you will do when you are doing endoscopy is you will suck out all the things from there. Then you can observe the esophagus for the signs of Barrett's esophagus or some localized tumorous lesions or other things, because tumors also can have the same presentation if it is causing obstruction of the lumen. So you have to be careful. You have to see the area carefully for any lesion in this in the lower esophageal region. Okay. Here the most you can say diagnostic, the most important diagnostic investigation is esophageal manometry. The esophageal manometry tells us the pressure of the esophagus in different parts. So when we are passing the probe and we are checking for the pressure in the esophagus, there is an area which is close to the lower part when there is no peristalsis, there is no actual peristalsis of the esophageal body, and the esophageal sphincter is very tight, and its pressure is very high. So we call it a hypertensive lower esophageal sphincter. So the part of the sphincter is hypertonic or hypertensive, but the lower half of the, or you can say the esophagus above it, is aperistaltic. There is no activity in that esophagus. So this is the typical finding of esophageal manometry in the patients with achalasia. Okay, diagnosis is by the manometry, and you have to be do other investigations also, because endoscopy is important in telling you the other complications that can happen, or the Barrett's, or the other space occupying gland in that area, and you have to add it in your diagnostic investigation. Now, treatment of achalasia is symptom relief. Here now we know that the problem is in the neuronal cells. We cannot reverse it properly, but we can relieve the symptom. You can offer the patient, just like the lifestyle modification we discussed in GERD, you can offer the same to the patient, because these collections of the fluid there, when they are collected in large amount, they can cause symptoms of acidity and acid reflux disease. Not the reflux disease, sorry, reflux of the contents of the esophagus back into the mouth. So there can be symptoms related to regurgitation, and there may be associated problems of aspiration. Now, what we can offer to the patient is medical therapy. We can offer treatment, medicines to dilate the lower esophageal sphincter. The common vasodilators we can advise to the patient, but usually they are of little value. We can offer botulinum toxin injection in the lower esophageal sphincter. Endoscopically, it is given, and it has if we don't want to operate the patient, it also has 50% good results. Pneumatic dilatation is one of the you can say also one of the easy procedure, in which we pass the dilators, and we pass the endoscope, and we do balloon dilatation of that area. But if not settling, surgical myotomy is the last resort. We cut open the lower esophageal sphincter, and we release the obstruction there. But the problem with the surgical myotomy is that patient may have the GERD symptoms afterwards, because now the lower esophageal sphincter will be relaxed, and patient may have the symptom of reflux disease. So you have to weigh your action. If your patient is symptomatic and intractable disease is not settling with all the other plans, then you have to go for surgical myotomy. Okay, pharmacological therapy, I've already said they are inconvenient, as they are not very effective. And we can have nitrates, vasodilators like nitrates or calcium channel blockers, but it depends. If you cannot offer any treatment to the patient, you at least can offer these vasodilators. This is how we introduce the botulinum toxin to the lower esophageal sphincter. This is again, it is used in those patients who cannot undergo any surgery, and they cannot take surgical intervention. You have to repeat it, because its efficacy is just for 6 to 12 months. After 12 months, patient need repeat injection. Pneumatic dilatation, it's good. About 70 to 80% is the success rate, and it has to be repeated. About 50% patient will need another session. Its complications are just like surgical myotomy. We have GERD, or sometimes esophageal perforations can occur, because you are doing it with pressure, and the wall of the that area is because of the effect of the food material there, the area is inflamed. And sometimes when we are doing it, there may be esophageal perforation. So we have to be very careful while we are performing this pneumatic dilatation. So the last resort is esophageal myotomy. What we do, we give NCN in the lower esophageal region, and we are going in till we are we reach the region where the mucosa pop out. When the mucosa pop out in the wound. That is the time where we have to stop, and this is the area of the muscle which we have cut open. Okay. Primary complications of eclasia, they are because of the functional obstruction it is causing. This could be malnutrition with the passage of time and aspiration pneumonia. But secondary complications, they may include the diverticular formation and esophageal squamous cell carcinoma because of the exposure of the mucosa to the irritant, to the acids. It causes the development of a malignancy. So that's why we said that when we are doing, we are investigating for eclasia, you have to do endoscopy by suctioning all the contents that are inside in the esophageal lumen, and then carefully, thoroughly inspect the area for any abnormal lesion there. Okay. Esophageal diverticulars. Diverticula are abnormal protrusion of the esophageal mucosa or esophageal wall from the muscular breaks. And the three most common sites are the pharyngoesophageal diverticula or the Zenker's diverticula, the parabronchial or the mid-esophageal diverticula, or the epinephric. You can see in the picture, these are the three varieties. The one that is present in the neck, this is called the pharyngoesophageal Zenker's diverticulum, or there may be parabronchial along the bronchi, or it could be epinephric diverticuli. Okay, the diverticuli, just like this is your pathophysiology, that diverticuli can be true or false. True, that contains all the three layers of the wall, all the layers, the mucosa, submucosa, muscularis, they all are part of that part or wall of the diverticula. If the diverticular wall just consists of mucosa or the submucosa, then we call it a false diverticula because it is because of the pressure difference, it is falsely coming out. So it's called a false diverticula. Okay, the false diverticula can be Zenker's diverticulum or the epinephric diverticulum, while the true diverticula, they are because of the traction. They are not because of pulsion, they are due to traction. And there can be external from inflammatory mediastinal lymph nodes that are adhering to the esophagus, and they are responsible for the true diverticula to form. Okay, Zenker's diverticulum, it's the most common esophageal diverticulum and disease of elderly. Old age patient, old age females can present with swelling in the neck region, that is on the side of the neck. And patient says that when I eat, when I take something, the swelling increases in size. And then with the passage of time, with the swelling decreases, and there is gurgling sound also when the swelling is reduced. So this is the presentation of Zenker's diverticula. Patient may have halitosis, bad breath coming out from the mouth. There may be voice changes, retrosternal pain, respiratory infections. They're very common because of this collection there. And most serious complication from an untreated diverticulum is aspiration. Patient is sleeping, the swelling, it causes, because of the posture change, all the contents of the swelling, they go inside into the esophagus or the food digestive tract. And as the patient is in lying down position, they may enter into the lung and they may cause aspiration pneumonia. So it is one of the most serious complication of an untreated diverticulum. Diagnosis we made is by barium enema, barium swallow. Patient is given a barium swallow, and what you can see is out pouch of the diverticula coming, that is lateral, that is on the side of the esophagus and causing compression symptom of the compression symptom on the esophagus. So patient presents with dysphagia also. Patient is having dysphagia and a swelling developing soon after eating food. What is the treatment? Treatment is you have to offer the patient surgical or endoscopic repair. We take out the whole diverticle because it is a false diverticular. So we just cut it off, we remove it, and we repair the defect. Okay. This because Anker's is more Anker's diverticulum is more common out of the 3 diverticula, so we just discussed about it. The rest are treated the same way if they are causing severe symptom. Otherwise, they usually don't. They are not very common. Barrett's esophagus. It is a precancerous condition. It is because of the reflux of the acid from the stomach into the esophagus. The part of the esophagus that is exposed to the acid, it becomes, it responds in a way that it changes itself. So it is associated with change of the esophagus epithelium from squamous to the columnar. We call it columnar metaplasia. So this is the hallmark of Barrett's esophagus. When we do the biopsy of that region, you can find the columnar metaplasia there. So squamous epithelium that normally lines the distal esophagus is replaced by columnar epithelium. Why it is doing this? Because compared to the squamous, columnar epithelium is more strong, and it is more resistant to the acid reflux. So the stomach, the esophagus, as it is trying to get rid of the injury from the acid, it changes itself from squamous to columnar. So the hallmark of Barrett's esophagus is columnar metaplasia. Although this is a protective mechanism, the epithelium was trying to make itself safe from acid, but on the other side, it becomes more prone to develop malignancy. So about 10% of the patient with GERD, they develop Barrett's esophagus, and Barrett's esophagus is a precursor. About 25% of these, they convert into malignancy. There is 40-fold increase in risk for developing esophageal carcinoma in patients with Barrett's esophagus. And this you can see here. With the continuous exposure, the cells are changed into a single layered columnar epithelium. And with the passage of time, these cells undergo cellular transformation and they go into the dysplasia. They go into a severe dysplasia. You can see the cells are dysplastic. Okay. Many patients harboring these metaplasia and their distal esophagus are asymptomatic. Most patients present with symptoms of GERD. Patients usually have the symptoms of GERD, and when we do endoscopy, we pick it out that this is a Barrett's esophagus. Diagnosis is by the endoscopy and pathology. Now, just revise for a minute. For GERD, what is the good investigation for diagnosis? That is, you have to go for pH monitoring. You do ambulatory pH monitoring. For eclasia, we go for manometry. Manometry tells us clearly that this is eclasia. For these Barrett's esophagus, we go for endoscopy and pathology. And for malignancy, also endoscopy and pathology. Okay. Treatment. If you are seeing a patient with Barrett's esophagus and there is no malignant transformation, you have to go for yearly surveillance. Every year you have to, after every 12 months, you have to call the patient and you have to take a biopsy from that area to confirm that there is no change in the behavior, there is no dysplasia started. And patient undergoing surveillance, they are put on acid suppression medications and they are monitored for their change in the reflux symptoms, whether this you can say sorry. Okay. Okay. So if you are doing endoscopy and you find a lesion there, can you see this central, please move this windows pop up? What is this? Can you see this, or it's not visible? Please move this window away from the shared application. Oh, okay, let me restart it. Just a minute. I don't know how to remove it. Okay, if you find a patient with Barrett's esophagus, a patient should be under your surveillance because their chances of developing malignancy is very high. So these patients should be put on acid suppression medications, and they should be monitored for reflux symptoms. They should be no further symptoms, as well as yearly endoscopy should be repeated to check for the development of the disease. Okay. Now, what is the algorithm for that for the Barrett's esophagus? If we have a patient with Barrett's esophagus and there is no dysplasia, you just have to keep the patient under surveillance, and you have to repeat the scopy first yearly and then every 3 years. If the Barrett's esophagus shows low-grade dysplasia, you have to repeat the endoscopy in 6 months' time, and then after 1 year. And if it is continued, if there is still dysplasia, you can go for endoscopic ablation of that lesion. If it is high-grade dysplasia, then you have to repeat your endoscopy by taking a second opinion, and then if the biopsy also confirms it, you can go for endoscopic or surgical treatment. Sometimes we do surgery and we remove that area of the esophagus and re-anastomose the esophagus, either re-anastomose or do some other anastomosis of the gut with the esophagus. So it, or we can make another pouch from the or we can take a limb of the jejunum and we replace it with the esophagus. So we can offer the surgical techniques, but you have to make sure that the patient is having a high-grade dysplasia, and if not, it is progressing towards the malignancy. So if it is high-grade dysplasia, you have to be very careful and you have to operate that area, or you have to treat it indefinite. Okay. These patients with Barrett's esophagus, they have been seen that they are benefited with the anti-reflux surgery, because the anti-reflux surgery causes the reflux activity of the acid, or the reflux of the acid into the esophagus is prevented, and the Barrett's esophagus is not developed further. There is no further dysplasia or the change. And what is what is the problem? What is the benefit of it? The surgery is causing the lower esophageal sphincters to become competent, and the reflux is no more there. And it has been seen that even the metaplasia regresses, and the normal mucosa comes back in 57% of the cases in the patients who undergoes the reflux surgery. Okay, we have discussed it that for high-grade dysplasia only, we go for esophageal resection, and it has been seen that 40% there is 40% risk of adenocarcinoma in these cases. That's why we are taking it as a serious case, and we operate the high-grade dysplasia patients. Okay, one more problem that patient may present with in surgical ward or the thoracic surgery ward, they are caustic injuries. It's very unfortunate that it is common in children because of the negligence from the parents, or because of the overactivity of the children. Sometimes what happens that parents, they put these caustic agents in close vicinity of the kids. Kids can go and can open it and can drink it, thinking it is something to drink. Sometimes they put these things in bottles that are reusing some bottles, like bottles of some juices, or bottle of some drinkable things. And a kid, by thinking it that something, it is some juice or something like that, they can drink it and they can ingest the caustic material. So it is advisable that in your home, try to keep these things out of the reach of children, as the consequences are very they're very devastating, they're very severe. So this is one group of this is one peak age group. Second peak age group is teenagers and adults. When they try to do suicide, they take it themselves. They voluntarily take these caustic things to for the they have suicidal attempts in plan, so they take these things. They may not die, but the consequences that they will suffer, they are worse than the deaths. And we have seen patients coming to us with caustic agent because of any reason, because of suicidal intention, or because of okay. Okay, yeah, the problem is that the esophagus is very sensitive area. We just saw that when the acid was coming and it was damaging it, it changes itself from squamous to columnar. The same is here. When the caustic soda comes in, esophagus is so affected by it that it causes structure formation. Even on the very first 3-4 days, patient will start developing features of strictures, and the cycle of dysphagia starts. This is the most you can say the most pathetic situation that ones suffer is the repeated structures form, and you dilate it, they form again, you dilate it, they form again, and they have a malignant potential also. With the repeated attempts and with the repeated structure growth, they may develop the malignancy. The squamous cell carcinoma may also develop in these. So it's not just it is not just that you are dealing a patient with the structures, and it's also that the patient may also be prone to develop malignancy. So you have to be very careful, and even sometimes when we are doing dilatations, there are esophageal perforations also. So even doing the dilatation is not you can say the safe procedure. It is associated with complications. Now, in the caustic injury, there may be alkali ingestions or acid ingestions. Alkali ingestion is more common than acid ingestion because acid, as soon as the patient put the acid in his mouth burns, so they don't continue it and they stop. But for alkalis, the ingestion is common because the immediate symptoms are not there. The symptoms are not immediate; they develop with a period of time. So they are when the patient comes to you, it has already been the time has already been passed, and the symptoms are more devastating, and there is significant destruction of the esophagus as well as of the stomach. Sometimes when it reaches the stomach, it causes destruction of the stomach mucosa and a problem in the stomach also. So there are 3 phases of tissue injury from the alkali ingestion. The first is the acute necrosis phase. which is in the first 4 days, till the first 4 days. And it is actually the inflammatory response. There is coagulation of the intracellular proteins, and there is inflammation going on in that process, and patient is unable to eat anything because of the pain and because of the inflammation there. Then from the next 4 to 12 days, patient has ulceration in that area. That whole lining becomes sloughed off because of the necrosis of the mucosa and the lining membrane, and there is severe you can say hematemesis, and the patient starts developing ulcers throughout the length of the esophagus. And then the last in the stage 3, in the phase 3, starts from the 3 weeks to continue till the whole duration. Patient has scarring and stricture formation, and there may be severe strictures formation in that area, in the affected area. Okay, in the first stage, patients usually complain of pain. They may complain of hypersalivation, orinophagia, painful swallowing, and dysphagia. There may be hematemesis and vomiting because of the inflammation and bleeding from the affected side. In stage 2, you only have dysphagia because of the fibrosis and scarring that has started, and it narrowed down the esophagus throughout the stage 2 and the stage 3. So it begins in stage 2 and then it continues. So from the third day, onward, the dysphagia becomes very prominent, and it continues later. And there may be other symptoms like respiratory distress, for instance, stridor and dyspnea, that suggest that there is upper respiratory edema, and these are more commonly to be seen with acid ingestion as compared to the alkali ingestion. Then patient may have, if there is associated complication of mediastinal esophagus perforation, or the perforation of the thoracic esophagus, they may have pain in the back of the chest and widening of the mediastinum. And if the patient is having abdominal pain or problem in the abdomen, upper abdomen, or the left side of the abdomen, think in your mind that it could be a stomach perforation or the esophageal abdominal esophageal perforation. So diagnosis is initiated with physical examination. You have to evaluate the patient from the mouth. You have to check for the airway. You have to check for the abdomen and the chest. And careful inspection of the lips, palate, pharynx, and larynx is needed. Usually in acid ingestion, patient comes to you with burn mouth from the and the inside, what he has taken inside is usually less. But in alkali ingestion, the ulcers in the mouth, even they develop later, not in the very first. There may be just hyperemia and inflammation of the oral cavity in the first 3 days, and then later on it becomes ulcerative, and there are ulcers in this area. You have to check abdomen and chest for the esophageal perforation, and maybe there is some esophageal perforation because of the extensive exposure, and it has caused the leakage. So early endoscopy is recommended. Why? Because as the disease will progress, endoscopy will be difficult. So as soon as the patient comes to you, you have to, once the patient is stable, you have to go for endoscopy. And you have to identify what is the extent of that burn, or what is the extent of that damage. And then you have to go for serial chest and abdominal radiograph to check for the status of the abdomen and the chest, to look for any perforation there, any air in the diaphragm or in the chest, any widened mediastinum, or signs of infection spreading into the lungs or the pleural cavity. Now, just leave this endoscopic grading, it's beyond your limit. Okay, management is depending on the phase, in which phase patient presents to you, you have to manage it accordingly. If the patient is coming soon after taking the caustic element, or the came soon after drinking, you have to identify it, and you should try to limit the extent. And what and how you can get it, you have to neutralize the ingested substance. If it is alkali, you can give vinegar, you can give citrus juice. But if it is acid, give water. You don't have to give the alkalis to neutralize it. You can give milk, you can give egg whites, you can give antacids, but don't go for alkalis. Okay, so you first thing is you will identify what is the problem, what patient has taken, and second, try to neutralize it. If it is alkali, give vinegar or citric juices. If it is acids, give milk, give egg whites also, because egg whites are also used as a neutralizer of acids. And then one important thing is don't make the patient vomit out. Don't make the patient vomit it out, because these are when the patient vomits out with pressure, the contents that are down in his stomach or in his esophagus, they are with pressure, they attack from the esophagus and they may cause perforation. So this should be avoided. You should not give you should not make the patient vomit. Now, if the patient is having first degree burn in that area, just the mucosa is damaged, you have to go for observation, and you should start oral nutrition as soon as the patient can pass his saliva down through the esophagus. Repeated endoscopy and barium swallows are needed at repeated intervals to search out for these strictures. And the second and third degree burn, when the burn is deep down, burn means the burn through the because of the caustic injury. So in these, resuscitation should be aggressively pursued. Patient should be kept NPO. They should be given IV fluids with IV antibiotics. PPI should be started. Then intubation, as we have said before, patient should be endoscoped earlier, from in 12 to 24 hours time. Try to do it earlier, because with the passage of time, the edema will be so much that you will not be able to pass the endoscope. And while you are doing it, you should pass a nasogastric tube also, because maybe the patient is unable to swallow later because of the edema, because of the structuring or damage to the whole wall. So what you have to do is you have to do endoscopy, as well as you have to pass the nasogastric tube from the nose into the stomach. Through the endoscope, you can put it there. Okay, and treatment is depending on the presentation. If there are strictures, you have to dilate them, and if the strictures are intractable, or there are intractable strictures, you dilate them, and they are so hard that you are unable to dilate them, then we can offer surgical replacements. We can replace loop of the jejunum, and we can place it instead of the affected esophagus there. So there are options, but for you it is it is important that you should know how to manage a patient with corrosive intake or with caustic injuries, and when you should do the endoscopy, and what is what should be the plan in different phases. What should you do in the different phases when the patient comes to you? Now, tumors, the esophageal tumors, it could be benign or malignant. Benign tumors can be tumors of the epithelium or the tumors of the mesothelium, and they can be the cysts. The tumors can be mucosal or extramucosal. Tumors, mucosal means they are arising from the mucosa, or extramucosal means they are mesothelium origin. They are originating from the area outside the mucosa, or in the area which is in the wall. So they can be leiomyomas, or these can be tumors of the vascular origin, or this can be cysts or polyps. Esophageal cysts, they are divertical of the embryonic foreguts, and usually these present in childhood, and usually these are on the right side of the esophagus. And think of these as a child presenting, an infant presenting to you in the first year of life with the respiratory esophageal symptom. Think about these cysts, and if you find such a cyst, you have to manage it in the first instance. Then there may be intraluminal tumors like polyps, and they are usually in old people, and they can have intermittent dysphagia, and they are easily missed with barium swallow and esophagoscopy, because it doesn't because these are intraluminal and they take what you can say, they are when you take the film, they are lined, and they may give you a false impression of something that is not very serious. So they sometimes they are missed. So what is the treatment of these polyps? You just have to remove them, and you have to go for a polypectomy. 60% of all benign tumors, they are leiomyomas. Leiomyoma, a tumor that arises from the muscular area, the muscular part of the esophageal wall. And if you can imagine, a tumor is developing in the wall, and it is lined by the normal mucosa. So when you are doing the endoscopy, you don't find anything, because there is nothing abnormal there. Mucosa is totally okay, but there is a mass behind it, and when you do the CT scan, you can identify where is the mass. So mucosa is not affected in the early phases. Later on, when if there is any malignant transformation, it becomes a leiomyosarcoma. Then that leiomyosarcoma can cause invasion of the mucosa, but usually leiomyoma does not have any invasion of the mucosa, and you can have a simple or you can say a smooth mucosa when you are doing the endoscopy. This is found more in man, slightly more in man than the females. It presents in usually 4th to 5th decade, and found in the distal 2/3 of the esophagus in more than 80% of the time. So these are usually solitary, and they are intramural. They cause symptoms as they enlarge. Usually there is no bleeding, there is no abnormal presentation unless until they become very large. And previously we were taking them as the muscle tumors, and they were named as leiomyoma, but now they are classified under the term of just the gastrointestinal stromal tumors. And these are tumors of the mesenchymal origin. Why we label them in the GIST? Because they also have the mutation of the c-KIT genes. And this is the hallmark of GIST tumors, that they have the mutation of the c-KIT oncogene. That's why leiomyoma are also now called a part of the GIST. These all are benign, and these are all tumors are benign, and the malignant transformation is very rare. Symptoms are usually they are asymptomatic. Patient may have dysphagia or pain. If the size is becoming big, then it is causing compression symptoms on the other areas or the surrounding structures. When we do barium esophagogram, we can have something that is just to show you. When we do the barium esophagogram, you can see protrusion that is causing specific defect in the lining of the barium swallow. You can see mass effect that is shown there in the barium esophagus, barium swallow. Okay, endoscopy, I told you when it is small, endoscopy doesn't tell us anything, but what sometimes it shows when it becomes big, that there is some extrinsic compression. The overlying mucosa is intact, there is no problem in that. When we go for an endoscopic ultrasound, we can see a mass in the submucosa or a mass in the muscularis propria. Okay. These are slow-growing tumors, and they are rarely malignant. So initially they're asymptomatic. With the passage of time, they become symptomatic. So initially we can offer observation to the patient if the lesion is very small, less than 2 centimeters. But if it is becoming bigger, we can offer surgical resection of the tumor. What we do is we go through thoracoscopy or through thoracotomy, and we enucleate the tumor with the whole of its covering. We don't have to open the mucosa in this. Mucosa is not touched, and the whole leiomyoma is taken out. This picture that you're seeing here, it is you are seeing it from the outside. This is the thoracic cavity. So you are seeing it from the outside, and after removing, this is the mucosa that we that bulges out when we remove the whole swelling, the whole tumor, and then we push in the mucosa and we just stitch it out. So that is the whole surgical enucleation procedure. This is the standard for these big leiomyomas or just tumors. Okay, then malignant tumors are of two common varieties: squamous cell carcinoma and adenocarcinoma. Now, use your common sense. Where are squamous cell carcinoma located and where are adenocarcinoma located? Any idea? Any student?
Hi, Doctor. My name is Yusuf. Squamous
Yes.
cell carcinoma are located are in the upper of the esophagus, and adenocarcinoma in the lower side of the esophagus.
Yes, comparatively, adenocarcinomas are more common in the lower esophagus because what we discussed before is the Barrett's esophagus. It is causing acid reflux, causing columnar metaplasia. This columnar metaplasia can become dysplasia, high-grade dysplasia, and later on it converts into adenocarcinoma. While squamous cell carcinoma that arises from the squamous epithelium, it can be in any part. Mostly it is in any part, but usually when we talk about in terms of squamous and adenocarcinoma, it is more in the upper part and adeno is more in the lower part. So squamous is throughout the length, it can be anywhere, but more it is in the upper third and adeno is in the lower third. Okay. There's a trend for this cancer that the incidence of adenocarcinoma was seen previously. It was very low as compared to the squamous cell carcinoma in the white males, but now it is seen that squamous cell carcinoma is going on a decline while adenocarcinoma is rising. The incidence of adenocarcinoma is increasing in white males. In the last 20-30 years, the trend has been changed, while in black males it remains the same. Squamous cell, give me a 1 minute break. I will start. There is a zone. Like that. Okay, squamous cell carcinoma arises from the squamous epithelium and squamous mucosa, and it's found in the upper and the middle third of the esophagus most of the time. Smoking and alcohol both increase the risk of this cancer by 5-fold combined. Food additives like nitrosamines found in pickled or smoked food, barbecue. Everyone likes barbecue, but barbecue is a risk factor for the development, or you can say it is a precursor for the development of cancers, squamous cell carcinomas. Then long-term ingestion of hot liquids, caustic ingestion, atlasia, bulimia, tylosis, Plummer-Vinson syndrome, external beam radiation, and esophageal diverticular. These all are the precancerous condition that may develop into squamous cell carcinoma. The survival of the patient based on the stage of the disease. That's why we are very careful while we are staging the patient. You have to stage the patient thoroughly because your management plan and the patient survival, they both are dependent on the stage of the disease. As per the 5-year survival, with the polypoidal lesions, the 5-year survival is about 70%. Polypoidal lesions that are not going deep into the esophageal diameter of the esophageal wall, but rather they protrude into the lumen. They have 70% 5-year survival rate, while advanced tumors that invade the structures or that have the potential to metastasize, they have 15% 5-year survival rate. Now, adenocarcinoma has a number of factors which are responsible for the progression of this cancer. Western diet causing the obesity, causing the increased incidence of gastroesophageal reflux disease, intake of caffeine, fats, acidic, more acidic things, spicy foods. All these, they cause change in the behavior of the lower esophageal sphincter. They decrease, all these decrease the tone of the lower esophageal sphincter, and they increase the reflux. And ultimately, what they are all causing is the development of Barrett's esophagus, the columnar metaplasia, and this columnar metaplasia is a risk factor, or you can say it has the tendency to change into adenocarcinoma in the future. 40% we said before that 40% of the Barrett's esophagus, they sooner or later they convert into adenocarcinomas. Early stage cancers may be asymptomatic, or they just have the symptoms of gastroesophageal reflux disease. Most patients with esophageal cancer, they present with dysphagia and weight loss. And this is when these symptoms are present, think about that patient may be having advanced stage. Because of the distensibility of the esophagus, a mass can obstruct 2/3 of the lumen before the symptoms of dysphagia are noted. The mass should be, the patients have dysphagia quite late when the mass is about obstructing about 2/3 of the lumen. Because this is like muscular, this is you can say fibromuscular tube, and it distends when the pressure, when it needs, when the food needs to pass, it distends. So usually patient don't have the symptoms of dysphagia unless until there is 2/3 lumen obstruction, luminal obstruction because of the tumor. Patient may have choking, coughing, and aspiration. If there is, if there are these symptoms, think about some association with the airways. There may be a tracheoesophageal fistula, a complication of an advanced tumor, or there may be vocal cord paralysis because of the and the hoarseness because of the involvement of the recurrent laryngeal nerve, direct or indirect invasion. And there may be systemic signs, systemic metastatic signs like mets to the liver, bone, or lung. They can present with jaundice, excessive pain, respiratory symptoms. Diagnosis is diagnosis you can offer radiological tests, endoscopic procedures, and minimally invasive surgical techniques. All are combined to reach up the stage of the disease, because stage of the disease is very important to treat the patient accordingly, because your early stage patients, they can present to you with a good prognosis after your surgical resection. A barium esophagogram, a barium swallow is recommended for any patient presenting with dysphagia, and it can differentiate between intraluminal or intramural lesions. And it can also differentiate between the intrinsic or the extrinsic compressions. We talked about eclasia, the classical finding of eclasia of a rat tail or bird's beak appearance, in which there is gradual narrowing of the esophagus, and then there is a tapering like the tail of a rat or the beak of a bird. But the classical finding of esophagogram, barium swallow in a patient with esophageal malignancy is an apple core lesion. Patient have sudden shouldering. If you can see here, if you can see here, is this. Oh, can you see my mouse?
Yes, we can see it, Doctor.
Okay, this is called shouldering. There is sudden shouldering. This is not gradual. Gradual is it's going down, 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 and becoming narrow. Here, when you see the barium swallow, there is sudden shouldering. There is sudden transverse shouldering of the tumor in the esophageal lumen, and then there is obstruction, or there is no failure, or there is no flow of the barium in the region of the narrowing, and then you can see some barium down in the stomach region or in the lower esophageal region. So this is because of this shouldering effect, is because of the tumors. And when we see on the barium swallow, it appears like an apple core. When we eat the apple, if you can imagine, when you eat an apple and you leave the upper part and the lower part, and you eat the central part, the appearance of that apple core after eating is the same as we can see here in the cases of adenocarcinoma, or the tumor of the esophagus. So the typical features or typical finding of esophageal cancer is an apple core lesion. The same is in the colonic cancer. The patients with colonic cancer, they have a classical findings of apple core. So apple core is malignant lesion, any malignant lesion presentation. There is abrupt shouldering, and then there is obstruction. Now, you can see it again here. There is sudden shouldering, and then there is downside. You can see that there is some barium down in the constricted part. Okay, endoscopy allows direct visualization. It can locate the tumor, and we can take biopsy with it. You can identify the lesion, and you can take multiple biopsies. CT scan is needed. It is recommended to stage the disease, because you not only have to look for the tumor T stage, but also for the N stage as well as for the metastasis. So we do the CT of the chest and the abdomen. We check for the tumor size and the tumor extension into the into the mediastinal region, as well as extending of its, or its extension into the other mediastinal tissues or other mediastinal structures. And for the distant disease, you have to check for the liver or and the lungs. You have to see the metastasis in the other areas. So CT is not only for the local disease, but also for the staging of the nodal and the metastatics level. Then PET scan. It evaluates the primary mass, the extent and the level of the primary mass, as well as the regional lymph nodes which are in that region. And it also gives us the benefit to identify the distant mets, the mets which are quite away from the original area of primary tumor. Endoscopy with the endoscopic ultrasound. It is the most critical component of esophageal cancer staging, because you are working in the lumen, but the and you can take biopsy only from the lumen, but the ultrasound probe that is with this endoscopic ultrasound, it tells you the exact depth of the tumor, how much the tumor has invaded into the surrounding tissue, and what is the extent of the lymph nodes involvement, whether the lymph nodes in the surroundings, they are involved or not. So endoscopic ultrasound is very critical in staging of this disease. Treatment depends on the clinical stage. At what stage patient is presented to you, you can offer the treatment accordingly. You can have surgical resection, can offer chemotherapy, radiotherapy, or immunotherapy. Usually we do multimodality therapy here. Keep it in mind, in patients with squamous cell carcinoma of non-obstructive variety, they are not obstructing the lumen to cause dysphagia. The small squamous cell carcinoma, radiotherapy is the best treatment. But for adenocarcinoma, the best treatment is surgery, because adenocarcinomas are usually radio resistant. Squamous cell carcinoma are radio sensitive, so we offer radiotherapy for the squamous cell carcinomas. But the adenocarcinomas, they are radio resistant, so we have to offer surgery to the patients in the very beginning, from the very beginning. So this is all about esophageal diseases, starting from the benign conditions that causing symptoms, as well as benign and the malignant tumors. Any question about this? Any question you want to ask? Any question you want to ask about it? esophageal conditions or the tumors. Okay, now take a break, say your prayer, and inshallah we will start the lecture at 12:40. Okay.
السلام عليكم. في صوت يا شباب؟
في صوت يا شباب.
Okay. Okay, I'll start the lecture. Start a screen share. Okay, this is the last lecture for today, and it's about the pediatric emergencies. You will, I think most of you have been through pediatrics. It is with your medicine. So I think most of you have done your pedia, and you have seen a lot of, you have taken a lot of things regarding pediatrics, so it will not be a difficult lecture for you, inshallah. Okay, the topic that I will discuss with you today, the acute appendicitis, problem that are related to the gut development, malrotation or the midgut volvulus, intussusception, pyloric stenosis, esophageal atresia, and rectal malformations, and Hirschsprung disease. These are the common conditions that are usually referred to pediatric surgery, which is a separate field from pedia. Pediatric surgery are the surgical specialty that deals with the pediatric patients. It is why it is a separate entity, because if you think about your from your knowledge of pedia, the kids are totally different from adults in many aspects, like their body surface area is different, their body's behavior or response to injury or trauma is different, even the response to surgery is different. So they are their surgical care is even the anesthesia requirement is different as compared to the adult. That's why we deal these cases separately in the pediatric surgery department, just separate from the adult surgical wards or theaters. Okay, the first topic that we will discuss today is appendicitis. Appendix is accessory organ. It's about 6 to 9 centimeter long, and it is present at the area where the three tinea of the cecum unite, and it is the base of the appendix where the three tinea unite. It is blind ending tube, and usually it is not involved in any active production or any active function of the body. And if you are performing a procedure on appendix, location of the appendix is very easy to identify from the tinea. We track down the tinea, and the point where the three tinea are converged, that is the base of the appendix. You can identify the base very easily, and then you can expose or you can dissect for the rest of the appendix. If it is inflamed, or if it is hidden from the site, or is it is retrocecal, or it is not visible, you can dissect it by first identifying the base. The most common cause of acute surgical abdomen in children and adolescents is acute appendicitis. Peak incidence is about 10 to 12 years of age. And why we are talking it separately here, because in children there is an increased risk of perforation in cases of acute appendicitis. Causes, now why the patient present with perforation earlier in children, that is also the reason is also very clear, because in children the policeman of the abdomen. What is the policeman of the abdomen? Who is the policeman of the abdomen? Any idea? Who is the policeman? Which structure in the abdomen is labeled as the policeman of the abdomen or the guard of the abdomen? Any idea? Level 12, any idea what structure is called the policeman of the abdomen? You have, this is from your anatomy. Mhm. Speak out if anyone knows, otherwise I will tell. Anyone knows, speak it out.
The momentum.
The greater momentum. We have the lesser momentum and the greater momentum. What are these? These are the peritoneal folds, or these are the mesothelial folds that are filled up of the fatty tissues, and they are called the policeman of the abdomen, because in the abdomen, what is the function of the policeman? Policeman tries to take care of the law and order situation. So in the abdomen, if there is any area of inflammation, any area where there is some irritation or some problem, some area of conflict, the greater momentum goes and stick to it, and it tries to localize the thing. So in cases of perforation, usually the even the inflammation, the greater momentum goes and stick to that area. But in children, the greater momentum is not fully developed. It is small in size, and if the kids they get acute appendicitis or inflammation of the appendix, the greater momentum is not there to seal it, and the infection it keeps on continuing, and later on there is early perforation. In adults, the perforation is not early because it is sealed or it is controlled or covered by the greater momentum. But in children, there is no covering, and the appendicitis or the appendix it perforates earlier. Causes of acute appendicitis are unclear, and it could be because of the luminal obstruction, because of fecolith or lymphoid hyperplasia or foreign body or tumor or parasite. There are many stages of the disease also. The stages can be clitoral stage when there is just some inflammation. Or it is phlegmonous stage, in which phlegmon is formed. That is because of the inflammatory reaction. The phlegmon it forms within the wall of the appendix, and then it is increasing in size. That phlegmon can develop into an abscess. Then there can be gangrenous appendicitis when the phlegmonous appendicitis is not settled, it's not treated in time. It leads to necrosis, ischemic necrosis of the vessel of the appendix. Obstruction of the vascular of the vessels, and there is ischemic necrosis of the wall of the appendix, and that wall becomes gangrenous. And when it becomes gangrenous, with the passage of time, it perforates. So there are 4 stages. Usually, patient present to us in the clitoral stage or the phlegmonous stage if it is suffering from too much fever. Late presentation usually can present as the gangrenous appendicitis or the perforated appendicitis. Now, this case scenario with 16 hours with diffuse discomfort initially, and now, and she had normal bowel movements the day before. So this is the usual presentation of acute appendicitis. And when these are examined, patients usually they sit still, and they usually fold their legs. Their legs are flexed. Their legs are flexed at the hip joint as well as at the knee joints. Temperature is mildly raised. Pulse is slightly high. Not too much, but slightly high. This is in case when there is clitoral inflammation. And if we examine the abdomen, there is localized tenderness in the right lower quadrant. Now, this patient presented to you with 16 hours history of abdominal pain, and now there is diffuse and now the pain has been shifted to the right lower quadrant. For acute appendicitis, shifting of the abdomen is hallmark. Initially, it starts in the central abdominal region because of the involvement of the visceral peritoneum. You will discuss it all in detail in your abdominal, the week in which you take the other abdominal lectures, hernia and acute abdomen and abdominal pain. But just to make you revise the things, because you have taken it also in your level 10. The initial inflammation, when there is catarrhal inflammation, what is happening? The problem is in the lumen of the appendix because of the obstruction. There is inflammation, and there is involvement of the visceral peritoneum only. The nerves that are in the visceral peritoneum, they are the they take the message of inflammation towards the brain. Brain take it as a problem related to the midgut, and because the appendix is a part of the midgut, and patient presents to you with problem in the mid abdomen. They say that I have problem. The kids, they usually complain, even the adults, they complain that they have pain in the central abdominal region, because this central abdominal region is the region of referral pain or the radiation of the pain of the midgut. So they usually present with a vague pain in the central region. But when the inflammation continues and after the inflammation of the visceral peritoneum, now it spreads to the initial visceral peritoneum, and now it spreads to the parietal peritoneum, which is around the appendix. Patient started experiencing pain in the specific region, because now the parietal peritoneum, which is lined by the somatic nerves are there. When they send the message to the brain analyze it, and now brain says, yes, okay, the problem is now in that specific region. So there is a visceral to peritoneal shifting of the pain. This is the hallmark of the appendicitis. Patients usually have a shifting of the pain from the central abdominal to the right iliac fossa or right lower quadrant, and this is because of the visceral to the peritoneal involvement. Okay. Any patient who presents with this problem, you can have the set of differentials in your mind. It could be appendicitis, it could be gastroenteritis, ovarian torsion at she's 12 years of age, UTI, or mesenteric lymphadenitis. You have to rule out these things one by one in your history. In gastroenteritis, you have to ask about the details of the patient's bowel movements and activity. Ovarian torsion, you have to ask about the history of the previous periods and if there is any previous symptoms before. In UTI, you have to ask about the symptoms of the urinary tract, and mesenteric lymphadenitis, you have to ask about the lymphadenitis in other areas. Like you have to ask about the history of sore throat. Usually the patients who have mesenteric lymphadenitis, they have history of sore throat also. So in the acute appendicitis, there is periumbilical pain, which is initially started there, and then it localizes to the right lower quadrant. And this pain is along with it, there is nausea and vomiting, anorexia, fever, and peritonitis sign. What is the sign of peritonitis? That patient tries to sit calm. Patient tries to sit still, doesn't move. So in peritonitis pain, as the pain worsens with movement, so patient doesn't like to walk and tries to sit still. As it is a 16 hours history, so you have to be very careful about the physical examination of the patient. The patient who looks unwell, lying still, should give you some suggestion that there is something fishy inside. There is slight tachycardia, there is slight fever, appearing to be dehydration is also one of the common feature. You have to, apart from these physical signs or the general signs, abdominal signs are also very important. One of the signs that we see in these patients is Rovsing sign. What is Rovsing sign? Rovsing sign is can you see the screen or can you see the board? Are you seeing the screen or the board? Okay. Okay, so the first, when we are palpating the abdomen, the first thing we saw on inspection that child is lying still, abdomen is not moving with respiration, or is trying to move, keep his abdomen less mobile, even with the respiration. So patient is lying still, and when you see the abdominal movements are reduced. Movement with the breathing, they are reduced. There is one sign that is called Rovsing sign. What is Rovsing sign? That when you are palpating the abdomen, when you palpating this part of the abdomen, patient feels pain in the other part. This is because of the involvement of the parietal peritoneum. The problem is here, but I'm not palpating here. I am palpating the left side, and the child feels pain in the right side. This is called Rovsing sign, that when you are exerting pressure in the left quadrant, patient feels pain in the right quadrant. Why is it so? Because when you are palpating, all the viscerals are pushed to the right side. And when the viscerals, they are exerting pressure on the parietal peritoneum, patient feels pain. So this is when there is peritonitis in that region, in that localized area, when there is peritonitis or severe inflammation, patient may feel a positive Rovsing sign. Then there may be, I will talk about the signs of acute appendicitis. There is, what is McBurney's point? Any idea what is McBurney's point? What is McBurney's point? You have to speak it out because I cannot open the chat. There is some problem with the screen sharing. Anyone knows what is McBurney's point?
Site of appendicitis.
Where is it? Where is it located? Where is it located?
The right lower part of the abdomen.
Sorry?
The right lower part of the abdomen.
Exact point. What is the exact point? It is your anatomy. You should know what is the exact point for acute appendicitis. Keep it in mind. This is a very common presentation in surgical emergencies. So you may come across patients while you are having rotation in surgery. So these will be, it should be clear to you because you will see such patients.
I think 10 centimeter to the from the umbilicus.
From the?
10 centimeters from umbilicus.
Any other idea? Any other accurate idea? Anyone else? This should be very. You all should know this. This is not a difficult thing. You all should know what is it. What is McBurney's point? What is McBurney's point? It is a point at the
It's a
junction
point.
of, sorry?
Isn't it the right side of the abdomen?
Yes, this is, I think the picture is coming opposite to you. This is my right side and this is my left side. Maybe you are seeing it opposite direction. Okay, this remember, this is the right side and this is the left side, okay? When I was writing the previous Why didn't you tell me that you cannot see the board normally? This is the mirror image now. Okay, just remember this is the, okay, I will make it the other way for you. This is the right now, and this is the left, okay? Now can you see it? This is the right, and this is the left, okay? This is the umbilicus, and this is the anterior superior iliac spine. Now, where is McBurney's point? It is the point where definitely we have the appendix beneath. This is the point at the junction of 2/3 and 1/3 of a line. 1/3 and 2/3 of a line joining the umbilicus and the anterior superior iliac spine. This is the imaginary line that we draw from the umbilicus to the anterior superior iliac spine, and at the junction of 2/3 and the 1/3 of it, 2/3 medial and 1/3 lateral. This point is called the McBurney's point, and for patients with acute appendicitis, if you palpate, or even if before palpating, there is a pointing sign, you say the patient where you have the pain. Patient will point to this region, I have pain here. And when you localized it, it is the McBurney's point most of the time. So there is a pointing sign. What is a pointing sign? Pointing sign is you will ask the patient to point for the pain. Patient will point, and he will point at the McBurney's point. That is the line joining the umbilicus and the anterior superior iliac spine. The junction of this line between the 2/3 and the 1/3 at the level of the 2/3 and the 1/3 of this line, you will have the most painful area. Patient will point with one finger that I have pain here. Okay, and there is one. This is tenderness, and there is another sign for it that's called the rebound tenderness. Rebound tenderness. What is rebound tenderness? If there is localized peritonitis, you put your hand on the McBurney's point and you press and you keep it for a period of time. And then suddenly you release your hand. You place your hand, you press down, and then you release. You take your hands away. What is happening when you are putting down? Patient had tenderness. When you kept it there for a period of time, the patient was not experiencing much pain. But as soon as you released your hand, the parietal peritoneum is suddenly separated from the visceral peritoneum, and patient had a severe pain. Patient develops a severe pain. This is called rebound tenderness, which the patient experiences when you press down and then release your hand. We will inshallah do this next time in the skill lab. I will tell you how to rule out or how to perform these signs of acute appendicitis. So there are many signs, and the important thing to remember is that these patients in the kids, if the history is prolonged, there are definite chances that the appendix may have been perforated. So you have to be very careful while you are investigating. And if there is diffuse peritonitis, the whole of the lower abdomen is painful. There is a positive Rovsing sign. It is a, you can say it is it's again causing the same problem. It is, there is a danger, there is a suspicion that the appendix have been perforated. So you have to look for the diffuse peritonitis sign. Okay. Usually investigations that we ask in these patients is the CBC and UTI and urinalysis, just to exclude the UTI, because UTI also present with the pain in the lower quadrants. So you have to rule out the urinary tract infections. And history is important, that you have to rule out the history of the sore throat. You have to, in females, you have to, if she is 12 years old, maybe she have not started her monthly cycle yet, but you have to ask about it carefully. Maybe in the earlier phase, that the things are more common. Then in females, mid-cyclical pain is also needed to be asked, not in this in the babies, but not in the kids, but above 12 years age or 11 years age, you have to ask about it also. And then imaging is not always needed, but sometimes when there are, especially in females, when there are suspicions, then we can go for an ultrasound. Ultrasound show us adjacent inflammation, not only the inflamed appendix, but also the adjacent inflammation, and there may be a periappendiceal fluid because of the inflammation. So why we are going for ultrasound? Because ultrasound has no radiation hazards. Just excuse me for a minute.
لحد ما الدكتورة ترجع اللي محضرش يروح يحضر أو اللي ناس يحضر.
Just sorry, I didn't unmute myself. Okay, ultrasound is good, and if it's a female patient, or if you're suspecting some other you're not very sure about the problem, then you can go for an ultrasound imaging, and you don't have any radiation hazards, so you can easily perform it. In CT scan, in cases where you are suspecting that there is some problem in identifying, and there may be some other like malignancy or other things that are associated with appendix, like carcinoids or other malignant lesions, you can offer a CT scan, but usually we don't go for it because it is associated with the radiation hazard. So in simple cases, what we have to do is first the clinical, first your diagnosis is clinical, and if needed, we can offer ultrasound. In some cases where the diagnosis is not clear, and the patient is having a lower abdominal pain, but you don't have any clear idea what is the pathology behind, you can offer CT scan. Or if you're suspecting something serious in intensity, you can go for CT scan. Okay. In ultrasound, what we have to see, it is the inflamed appendix, the pericholecystic fluid around it, and the inflammation extending into the surrounding tissue. Okay, so what is the treatment? Treatment is if you are confirmed that this is acute appendicitis on the basis of clinical diagnosis as well as with the ultrasound or other investigations, you have to make the patient NPO. You have to give IV fluids to the patient. If you are to start it, if the patient comes to you earlier, you have to go for, you don't have to give the antibiotics for long, just you have to give one pre-operative dose of antibiotic for the simple cases. But if it is sure that patient is having a long history, then you have to start the antibiotics regime. You have to go for urgent appendectomy. You can do it open or laparoscopic, and in both the cases, patient can go home next day. Usually in simple cases, we don't require antibiotics, just as I said before, but only one pre-op dose and 2 post-op doses is the usual recommendation. But if there is a chances of perforation, we are suspecting that there is gangrenous or perforated appendix, complete regime. Okay, and ruptured or perforated appendicitis, usually patient present to you late. Even the presentation is either the presentation is delayed or the diagnosis or the treatment is delayed. Patient can become very sick, may present to you in septic shock, and you have to do urgent appendectomy unless the investigations show you an abscess cavity. And if it is the perforated appendix or ruptured appendix, you can go for appendectomy. But if it is an abscess, surgery at that time is contraindicated. What you have to do is you just have to start antibiotics to the patient. If there is a abscess localization, you can go for a percutaneous insertion of drain, and we go for interval appendectomy. Usually, it is seen that why we are not going for surgery in these cases, because that localized abscess which has been localized there, if you go and open the abdomen and start manipulating there, you will extend the disease. Second, these abscesses, they can be controlled with antibiotics. So on the antibiotics is the cure, and when the patient comes to us after a period of time, and we try to do a scan or ultrasound, there is no appendix, because the appendix, when it becomes an abscess, it becomes eaten up by the, or it becomes resolved by the abscess or the phlegmon there. So usually if needed, we go for an interval appendectomy after 6 to 8 weeks. But usually when we see the patient in the follow-up period, we don't find any appendix there. For these complicated cases, recovery is prolonged. So the patient needs to be stayed in the hospital for a period of time, 3-4 days, and you have to give post-operatively intravenous antibiotics. There is high risk of superficial or deep abdominal infection, so you have to be very careful about the antibiotic you choose and care of the wound. One more important thing is we don't close the skin incision in ruptured or perforated appendicitis. Why? Because there are more chances of development of internal collections and abdominal infection. So we keep the skin open. All the ooze, it has the place to come out. So all the ooze, all the infectious collection inside, it comes out through the wound. If you close it, it will remain inside and it will create more problem for you. It will form deep abscesses. So we operate the perforated appendix or ruptured appendix, but we try not to close the skin sutures if we are expecting, if we are seeing or there is frank pus there, frank collection of dirty fluid. You can see here there is a perforation, and you can see the internal feculates coming out of that part. Okay, second is this is all about appendicitis in kids. Early presentation has good recovery, earlier recovery, but late presentation usually presents with complications, ruptured or perforation, and the recovery is a bit delayed. Now, second important problem that kids may present to you in the pediatric surgery, they are the malrotation or the midgut volvulus. Usually during the immunological growth, the initial formation of the alimentary tract is like a straight gut, and later on it goes through different rotation transformations, and it acquires its normal position. The gut, different parts of the gut acquires a normal position within the abdomen. So there are, if there is any defect in the rotation of the gut during the during the embryological phase, we have the problems of intestinal malrotation. So if you see this picture, this is the normal gut rotation, that you have stomach on the right side, then duodenum and the jejunum on the left side, and then the whole gut in the central part, and then seek the large gut makes the shape of a you can say it makes the shape of a square, and it surrounds all of the small bowel. But if there is malrotation, and this is the tract of the mesentery in between. But if there is gut malrotation, what happens, that whole of the upper gut is on one side of the abdomen, whole of the lower gut is on the other side of the abdomen. So there is a problem in this is the presentation if there is no rotation of the gut throughout this embryological phase. It occurs, the normal rotation occurs about 4 to 12 weeks of the fetal life. And then there is a counterclockwise movement of the gut. It goes in a way that it causes the viscera to be settled in its specific place. But if there is no rotation, then the visceras have their different places. This is your embryological revision of your embryology, if you remember. Okay, I'm not going into the detail of it. Okay. Why we are what is the problem that a patient may suffer if there is malrotation? So these are usually children, usually the infants, which develop symptoms because of the obstruction of some part of the bowel, or twisting causing the obstruction to the vasculature of some part of the bowel. So there may be bilious vomiting if there is a band that obstructs the duodenum because of its malrotation, or because of it's not in its actual position. So that band, which is actually which was meant to keep the things in position, now it is stretched around the duodenum, and it causes duodenal obstruction and causes bilious vomiting. There may be midgut volvulus because the midgut is now in it's not like in its proper place, and it is just like an easy to rotate thing, and when it is rotated, it twisted, it causes ischemia or the bowel gangrene because of the obstruction of the mesentery of the midgut. This midgut volvulus is very important because if it is not identified quickly, patient may die because of the septic shock. And if it does not die, the entire bowel will be lost. There will be short bowel syndrome. Why? Because there will be ischemic necrosis of the bowel area, and that ischemic necrosis will cause that part of the bowel to become gangrenous and perforated, and we remove it. So it is in a small infant, when he presents to us with the symptoms of malrotation problem, and on investigation it confirms it. You have to be very careful, because these are the conditions that are not compatible with life. You have to be very careful while you are doing it. And even if you operate it, the whole gut will be you have to take the whole gut out, because the whole gut is involved in this malrotation, in this volvulus, and that short bowel, it is causing too much electrolyte imbalances, too much problems, and it is not compatible with the life of the child. Okay. So usually the infants, they present in the first month of the life, and about 15%, 75% present in the first month of the life, and about 15% they present in the first year. And the cardinal symptom is bilious vomiting. Why? Because there is obstruction to the duodenum, and it is distal to the opening of the bile duct. So the bile that is entering from the bile duct into the gut, into the duodenum, it is entering into the duodenum, but it is blocked. Its pathway is blocked. So that bile comes out of the stomach and to the mouth, and it's green in color. So the vomitus of the child is green in color. So if you have a patient presenting to you with bilious vomiting, you have to be aware of midgut volvulus, especially in children in infants. Other symptoms can be abdominal pain. Child cannot tell you about the abdominal pain, but it's all the time crying, and the abdomen is painful to touch. The abdomen is initially scaphoid because of the malnutrition, but later on, because of the ischemia and all the complications, it becomes distended, and there may be rectal bleed. The infant that you see here, they are lethargic, dehydrated. They are in shock sometimes because of the septicemia. They fever depends on the infectious status. Abdomen is and then later on with the passage of the and swollen. And in the late phases, you may find abdominal wall erythema when the inflammation or the problem is spreads towards the to the parietal peritoneum, and the abdominal wall is affected by it. How to investigate it? If we do the abdominal X-ray, it could be totally normal, but what you'll find is a dilated stomach only. Upper GI study is the gold standard to diagnose the malrotation. It takes time. So if you are suspecting a patient is having bowel ischemia, you should not go for this, or you should wait for the things to be settled, because upper GI contrast studies, they contain the contrast media, the contrast solution, and that if there is ischemia and there is some impending perforation and you give these contrast agents, they may they may promote promotion, or once they are in the peritoneum, they are very difficult to be cleared away later on. So you have to be very careful when you are doing the upper GI contrast studies. Here, in the contrast study, you can see that the stomach is very much distended, and there is very slow movement or flow of the contents into the small intestine or the rest of the gut. And post contrast, you can see that there is a big dilated stomach here. This can be a post contrast slide, or it can be a simple chest X-ray. In both cases, you can see that there is a very big stomach, and the rest of the gut loops, you cannot see the air in it. Here, there is no air in it. Okay. What is the treatment of it? Treatment is you have to offer intravenous fluids. You have to keep the patient NPO, and you have to offer or you have to start the IV fluids. Patient should be put on NG tube to decompress the stomach. Broad spectrum antibiotics are started, and immediate surgical consultation is required here. What we do here is a LATS procedure, in which you just have to untwist the bowel. You have to open the abdomen. You have to untwist the bowel. The twisting that is causing the ischemia, you should reverse it. This twisting is usually in the if it is clockwise, you have to twist it, and counterclockwise, and then you have to identify the LATS band, and you have to resect it. You have to cut it. If some part of the intestine is gangrenous, you have to resect that also, and you have to make sure that the bowel is compatible or viable when you do the anastomosis. Then the bowel is placed in the non-rotation position, and we close the abdomen. This is the LATS procedure. You can see there is a this is the LATS procedure. You can see that this whole bowel is twisted. This is the mesentery of the bowel, and this is twisted here in this place. You can see here, this is the LATS band that is causing the main problem. So what you will do, you will cut the band. This is the LATS band here. You will cut this band, and you will untwist the gut. You will make it untwist so that the ischemic effect of that twisting is gone, and then you leave the gut in a in a way you cannot make it, or you cannot re-rotate it to the like the normal person, but at least you have to cut the lad band. This lad band is the main person which is the main culprit which is responsible for the twisting. It is attached here and it causes gut to rotate on it. So what you have to do is you will cut the band and you will untwist the gut. If the gut is viable, the child is usually responds. But in delayed treatment, if you don't do the treatment in time, what can happen? The whole of the gut can become gangrenous, and there may be ischemic necrosis. So you just have to go for a short bowel, a whole of the short bowel resection. The delayed diagnosis can present as bowel gangrene or short bowel syndrome, septic shock. Ultimately, all these causes multi-organ failure and death. I will share with you a video about how the gut rotates and how the things they are arranged, or how the things are arranged, the normal abdomen, and what happens here, and how the lad band is causing the things to twist. I will inshallah share it to your Moodle account today. Okay, then intussusception. Intussusception is if you look at my screen, look at my board, and I will explain it to you. When a part of the intestine invaginates into adjacent part, this is intestine, this whole is the intestine. Okay, now this part of the intestine, it invaginates, it goes inside this part, suppose this goes inside and it moves and enters into the adjacent part, into this part. This is called intussusception. This is a normal gut. This part moves forward and it goes inside the other part. Now, this part is under severe tension because it has one thing has entered into the next adjacent part. So this part, which is the neck, this is the neck of this intercepting segment. It is under severe pressure. It is under severe you can say compression, and it undergoes necrosis. So intussusception is actually compression of the bowel because of invagination of one part of the bowel into the adjacent. Look, you can see in this picture very clearly. And when the bowel is compressed, its venous obstruction is venous drainage is obstructed. This causes bowel wall edema, and bowel wall edema is causing further pressure on the bowel. The edema is also causing further compression on the bowel wall, and later on there is arterial insufficiency. And when there is arterial obstruction, there is ischemia, and later on it can present as a perforated obstruction. So it is in 95% of cases idiopathic. There is no cause behind it, and seen to be because of some increased in the size of the Peyer's patches because of infection or because of generalized lymphadenopathies. Pathologically, sometimes there is a pathological lead point. There is some lead point, or there is something attached to this part of the bowel that pushes this proximal part into this distal part. This is the distal part. This is the proximal part. There is some tumor, there is some polyp, there is maybe Meckel's diverticulum and this point, the lead point. They, with the passage of the flow of the contents of the gut, they are pushed forward, and they are pushed forward to such an extent that they enter into the adjacent bowel loop. So what is happening here? Look, you can see that when this part is entering into the other part, the mesentery between them is compressed, and it causes obstruction to the veins and the arteries, and there is later on the ischemia of the bowel wall. This is the lead point. You can see there is a tumorous polyp here, or there is a polyp here, and that polyp is pushing the proximal part into the distal part, and while it is going there, it is causing the compromise of the blood supply to that region. Okay, usually in children it presents about 3 months to 3 years of age. There is episodic pain, abdominal pain. Between the attacks, because there is a lead point, because there is some you can say there are some recurrent attacks. So the child is well between those attacks. When there is intussusception, the child is having the pain and all the other symptoms. But when with the passage of time, the intussusception is resolved, child is okay. So child is well in between these attacks. They may have bilious vomiting. The important point for these kids that you should ask from the parent is, what is the color of the stool and what is the nature of the stool? Usually the parents say that they you can give them the hint. Usually they are like red currants or the red berries. They are like red berries jam, red berries jelly. The stools are like that. They are their consistency is not very thin, not very thick. It is like a jelly, and it is like its color is like of the red currants. So it is called red currant jelly stools. When you see the abdomen, when you palpate the abdomen, abdomen has sausage-shaped mass. Sausage-shaped mass, like sausages are used in you know what are sausages used in sandwich making. So if you palpate, there is a sausage-shaped mass in the right upper quadrant, and when you palpate the right lower quadrant, that is emptied. There is no right lower quadrant. The whole of the small intestine, the whole of the terminal ileum has gone into the colon till the level of the right upper quadrant. So patient usually presents with bilious vomiting, red currant jelly stool, and there is a sausage-shaped mass in the right upper quadrant. In 65% of the cases, this is the most common presentation. And when we palpate the right lower quadrant, it is usually empty. Okay, imaging. In imaging, what you can see is the gold standard is ultrasound, because it gives you the target sign. You can see in this ultrasound, you can see the target sign. It's like this is the target sign. This is the target sign. Okay, just like that you can see on the ultrasound scan. If you do the ultrasound scan, this picture is very clear on the ultrasound. So it is gold standard for intussusceptions. Rest, we can go for abdominal ultrasounds. What you can see are just the dilated bowel loops and maybe a right upper quadrant mass because of the whole intussusceptum and the whole mass going towards the right upper quadrant. So we will have a mass there. There may be dilated bowel and the air fluid levels because of the obstruction. And the gold standard is, and the ultrasound, when we go for the ultrasound, we have this target sign. Okay. Okay, for what is the treatment? Again, if child present to you with obstruction, you have to keep him NPO, you have to give him IV fluids. If bilious vomiting, you have to pass the NG tube and you have to decompress the stomach. Then first we try to give reduction enemas. What are reduction enemas? These are enemas that are given with pressure through the parectal route. And these are usually a fluoroscopic guidance because we are giving it, we are giving the dye in it. So we can check it fluoroscopically whether the dye has, whether it has caused the invaginated portion to go back. What we want to do actually, that this is the part that has invaginated inside. So we are giving enemas, and what are we trying? We are trying to make it go back to its normal place. We are trying to move it back. So this is the first step that we do. We give reduction enemas, and we try to do it non-invasively. But if it is not settling, then or you cannot do it, then you have to go for surgical reduction, and you have to, if that area is viable, you can just reverse it. If that area is having some lead point inside, there is some polyp, or there is some Meckel's diverticulum, or anything that is causing this problem, you have to operate, you have to repair, cut it and repair it. If the gut is non-viable, then you have to look carefully for the vascularity, and you have to cut the area which is avascularized or which is ischemic. Okay. This is all about intussusception. The presentation is should be in your mind when you are watching such a patient, such a kid with the intestinal obstruction. If you find a kid who's with bilious vomiting or vomiting with red currant jelly stools, and when you palpate the abdomen, there is a mass, a sausage-shaped mass in the right upper quadrant, and when you palpate the lower quadrant, right lower quadrant, there is nothing in there, it is empty. So you should have a strong suspicion that this is intussusception. Okay. Another important topic is hypertrophic pyloric stenosis. Hypertrophic pyloric stenosis is usually it presents around in the early infancy, less than a month-year-old child, and there is gastric outlet obstruction because of the hypertrophied pyloric muscle. One thing we did today in the esophagus lectures about eclasia, we did talk about that there is esophageal sphincters overactivity. Now here in the hypertrophic pyloric stenosis, the pyloric muscle is hypertrophied and it causes obstruction here in this area. So this is called gastric outlet obstruction, and the pylorus, because of the stenosis, it doesn't let the food materials to go out of the stomach. How to differentiate a child presenting to you with vomiting? How to differentiate that this problem is because of the midgut volvulus, or a problem later, problem beneath problem of the gut, or it is a problem of the stomach? How you can differentiate? Any idea? A child is presenting with vomiting and he is having abdominal pain. By seeing the vomitus, can you say anything about it, that this is what
projectile vomiting?
Sorry?
Projectile vomiting?
No, projectile vomiting can be in both the cases. Any other thing about vomiting can tell you that this is what and this is what. What term we used for the vomiting of
hungry after vomiting, the baby?
This is common. Every child will be hungry when he vomits out everything from his gut. Anything else? But this is non-specific. Color. What is the color of the vomitus? What will be the color of the vomitus in hypertrophic pyloric stenosis?
Yellow.
Yellow. Or the color of the things that he has eaten. If he is taking milk, that will all come out. But in the cases of the gut problem, midgut volvulus or intussusception, patient will have bilious vomiting. So here we call it, there is non-bilious vomiting in gastric outlet obstruction due to pyloric stenosis. Okay, what is the classic triad? It is a full-term baby and usually presents to us in 2 to 8 weeks of life with projectile non-bilious vomiting. Okay, and when we do the routine examination of the baby, he is hungry, he is dehydrated, hungry because he is not anything he is eating, he is vomiting it out. It is not going forward. So he is hungry, he is dehydrated. When we palpate the abdomen, there is a you can see here. Sorry. You can see here, just above the umbilicus, there is about 3 centimeters above the umbilicus, there is a mass, which you can see here. This is called the olive sign. This is the palpable pyloric muscle, which can be palpated. And when you see the abdomen of the child, there is visible peristalsis moving from the right to from the left to the right. So the physical findings that you can see there, sorry, the classical triad is of a full-term baby with developing the symptoms of projectile vomiting, non-bilious vomiting, specifically non-bilious vomiting at 2 to 8 weeks of life. And when you examine it, there is a mass in the epigastric region, and you can see the visible peristalsis. So it's usually labeled as a hypertrophic pyloric stenosis, unless proved otherwise. And important thing is, what is the electrolyte abnormalities here? What is the child vomiting out? He is vomiting out all the acid that is found in his stomach. So, and along with that, in exchange, there is potassium loss also. So child will have hypochloremic metabolic alkalosis. We call it hypochloremic metabolic alkalosis with hypokalemia. So this is the electrolyte abnormality that we have here. Inshallah, when we'll do the fluid and electrolyte balance, I will explain this to you, how this whole electrolyte imbalance is going on. But today I will not go into the detail of it. So for the hypertrophic pyloric stenosis, keep it in mind, there is hypochloremic metabolic alkalosis. Why alkalosis? Because acid is thrown out of the mouth. So what is left behind is more alkali. So there is metabolic alkalosis, and along with it, there is hypokalemia because of the exchange, and there is hypochloremia. Okay. Okay. For pyloric stenosis, the gold standard investigation of choice is ultrasound. Ultrasound shows the thick and elongated pyloric muscle. Think about all these problems of the soft tissues, either ultrasound or if in adults we are talking about something of soft tissue, MRI is the gold standard. So usually in children, these problems, they are being resolved by the ultrasound. Ultrasound is the gold standard to pick these things. How we manage it? We will NPO the patient. We will give him IV fluids. We will correct these electrolyte and pH imbalances. And then, just like we did for myotomy for the oropharyngeal sphincter, the same way we will do pyloromyotomy for this. What we do, we open the abdomen by rooftop incision. Incision at the level of the stomach, above the stomach. It's not a laparotomy incision, a small incision that is given at the in the epigastric region, and we reach the pyloric region, and we feel that there is a lump or a mass there, and then we give a slit. We give a slit to the covering or the wall of the stomach, and we keep on doing it till we cut all the muscles and the mucosa pop out, just like the mucosa pop out in the previous myotomy that we did in lower esophageal sphincter. Okay, this is the this second pylorus, you can see that we give a slit, a transverse slit, and this slit is extended down till the mucosa pop out. We don't have to damage the mucosa, because otherwise we have to make the patient NPO for more days, as we have opened the gut, and we have to be, the patient will remain in the recovery for more time. So this is all about the pyloric stenosis. The treatment is pyloromyotomy, done under general anesthesia. Okay. Another condition that childs present in the emergency of pediatric surgery, this is esophageal atresia with or without tracheoesophageal fistulas. Esophageal atresias are interruption in the continuity of the esophagus, and these can be with fistulas, with the trachea, or without any fistula. And these are actually the errors in separation of the esophagus and the trachea during the 4th week of gestation. Usually the infants are male as compared to the females, and in most of the cases, about 50 to 60% of the cases, there are other associated anomalies also. The vectoral spectrum of disease is also there. You have the associated anomalies of the vertebrae, anal canal, heart, tracheoesophageal tree, renal, and the limb. So this is a vectoral spectrum or group of anomalies that esophageal atresia is a part of. Esophageal atresia, or with or without fistula, is a part of this spectrum. Okay, it is 4 varieties. Sometimes it is just tracheoesophageal, it is just esophageal atresia, or it is the esophageal atresia with a blind pouch of the with a blind pouch, and the other part is totally uninterrupted. In the first, the one is not mentioned here. In one, there is some communication between the two, and you can brought the two together. In the 2A that's mentioned here, you can see that both are blind endings. There is no communication between the two. In third, there is a blind ending of a blind ending esophageal atresia with a tracheoesophageal fistula. And in other variety, there is a tracheoesophageal fistula where the lower part of the esophagus is having a fistula with the trachea. Upper part is a blind pouch. Or sometimes they both are having a fistula with a trachea. And in some cases of severe intensity, you have continuity of the column, but with a fistula formation between the two loops, the trachea and the esophagus. Usually a patient are picked prenatally if the child is having polyhydramnios, if there is too much fluid inside in the amniotic cavity. You have to be aware, and you have to go for scans to rule out what is the problem, because esophageal atresia is one of the cause of polyhydramnios. So you can pick it prenatally, or you can pick it postnatally if the child, if the baby, the young born baby presents to you with drooling, vomiting, and respiratory distress after taking any meal. And when you pass the nasogastric tube, it doesn't goes into the stomach, it coils in the chest, it doesn't go down. You can see in this picture, this is the nasogastric tube we just tried to put inside, but it instead going down, it is coiled here in the upper part of the chest. So this is called obstruction or resistance on insertion. Okay. Treatment is you have to offer urgent surgery for this. You go for a right thoracotomy, and we divide the fistula and we repair the esophagus. If delayed, there are complications like respiratory, repeated respiratory infection, and the survival of the child is very questionable. So as early as you pick it, you have to operate the patient, you have to divide, no connection between the two blind pouches. You can take a piece of gut and you can replace it, and you can place it between the two areas. So it is very important that you make the continuity of the gut again. Okay, this is all about esophageal atresia. So the next common presentation is imperforate anus. What is imperforate anus? Again, just like esophageal atresia, it is a part of the vectoral anomalies. About 65% of imperforate anus, they are associated with it. It is a failure of anus to form. Normal anus is about located at the center of the normal anus. It develops from the cloaca. If you remember your embryology, the cloacal membrane is going down. It proceeds caudally, and the anus, which is present in the lower part, a dimpling in the skin, it moves upward, and both these, they join together, and then anus is formed. So anal canal is actually the combination of these two. That's why we say that anal canal has half part squamous and half part columnar epithelium, and the dentate line differentiates between the two parts, because the lower part rises from the skin because of the invagination of the skin inside, and the upper part is coming from the through the downward descent of the cloacal membrane. Now, there are various forms of this anomaly. In some forms, you can find a lower anus in the normal position. But in some forms, there is no dimpling, there is no anal canal. And in some cases, you may find some dimpling with a, what you call the external sphincter present there. So the variations, there is variations in the in the development of this condition. Okay, this is, if you have just a minute. Okay, what is happening here? This is again, where is the opening? Sometimes in females, the openings can be in the perineal region, it can be in the vestibule, it can be a persistent cloaca, and it can be an imperforate anus without any fistula, or it can be rectal atresia. There is no rectum at all, not at all formation of the rectum. In male, there can be perineal fistula, rectourethral fistula, rectum entering into the urethra. Patient is passing or the kid is passing the stools from the urethral site, and there is severe infections again and again. They may the opening may be at the rectovesical region, causing the rectovesical fistula. It could be an imperforate anus without a fistula or a rectal atresia. Okay. This is you cannot understand it. Okay, I will try to tell you what is it. Okay, this is the anal canal. If you this is the rectum. Okay, this is the rectum, and this is the part of the anal canal. Now this is the anus. What happened here? That instead of coming down and making a communication with this anal canal, the anal canal part that is coming up from the upper area, it started growing anteriorly, and it comes out through the vestibular part, from the vestibule of the female genital tract. So what is happening here? You may come across a patient having some dimpling here. If you see, the skin is intact. The skin is intact. There is no anus. But where is this rectum and the upper anal canal opening? They're opening in the vestibule. Patient presents to you, sometimes patient presents to you in later age. I have seen 2-3 patients at very late age. One Saudi patient, I saw her when she was in 60s. And she had the problem that initially she was unable to control her stools. She was passing the stools without any she has to take very care, because she had no control on her stools. She had soiling of the clothes all the time and other problems because her anus was imperforate. There was no anus here. Where was her stools coming out from? They are coming out from the perineal region. One female patient we saw many years back, she was again having the same problem. She had no control. She was big girl, about 20 years old female. She had no control on her stools, and all this was when she was all this was noted as she was part of a syndrome. She was having some just like we talked about the vectoral syndrome, the vectoral spectrum of the diseases. She was a part of that anomaly, and she was identified while we were investigating her for some other reason, and she was appeared to be suffering from this also. So these anomalies, they are many a time they are combined together, and usually the patient presents to you late. So if you are it is very important that when a child is born, all his orifices should be checked, because this is if it's late, then the patient usually doesn't understand what is happening, and he usually presents late, and at that time the muscle function muscles don't perform well at that time. So you have to do if you are having a patient with a normal look, this is the internal sphincter, this is the external sphincter. If you have a patient, if you have a child with patent sphincter, try to operate it earlier. Okay, so what is happening here? The perforation of the anus is not present. This anal canal is a bit grown because you can see the external sphincter here, but anal canal mucosa is not developed. So what happened? The upper anal canal is joined to the perineal region. It is opening to the perineal region. Patient is passing stools with no control. There is no control on the stools because external sphincter is not active. It is not there. Okay. So when we examine the kid, when we examine the baby, what we can see is there is an opening other than the normal openings in that specific area. You may have an opening in the vestibule. You may have an opening behind the vestibule. You may have an opening in area other than the anal canal region, and the anus is closed. Here you can see the anus is the anus is not perforated. We call it imperforate anus. Sometimes it presents with perineal fistula, sometimes vestibular and sometimes perineal. This is a male patient. You can see this is the area of the anal canal, but it is imperforate, and the anal canal is opening through the skin of the perineum as a perineal fistula. Again, this will not have any control. Then it can open into the urethra as a rectourethral fistula, and patient can present to you with urinary obstruction, urethral obstruction, and severe UTIs again and again. What is treatment? Treatment is we try to do primary anaplasty, and if it is delayed, if the conditions are not good and you cannot do primary closure, you can offer a delayed anaplasty. And for the time being, we do colostomy. We take out the gut loop outside, and we give time to the patient to control the infection and control the growth of the tissue. We're talking about kids, so about growth of the tissues. And then once suitable and the infection is resolved, we can go for an delayed anaplasty. Okay. The last of these titles is heart-sprung disease. Heart-sprung disease is disease in which there is absence of the ganglion cells in the myenteric and the mucosal plexus of the intestine. What is happening here is there is arrest in the cells migration from the proximal to the distal part of the gut. And there is a transition zone. There is an area between the normal and the aganglionated bowel. about 80% of these region of this aganglionic segment is in the rectosigmoid region. About 10% is in the proximal colon, and in 5% of cases, we can find them in the colon, rest of the colon. Very rarely it is total intestinal. Very rarely it is total involving the whole gut is starting from the stomach till the starting from the small intestine till the large intestine. So usually 80% of the cases we find this disease or aganglionic segment in the rectosigmoid junction. What is the problem here? What is the function of the ganglionic cells? They cause the motility of the gut, and they make it relaxed. But as those ganglionic cells are not there, the gut is constricted. The gut is, you can say, it is in the condition of spasm, and that causes obstruction to the flow of the stool or passage of the stool, and child may present to you like thread-like stools, very common thread-like stools, or severe constipation from early childhood. So usually neonatal presentation is delayed passage of meconium, more than 24 hours, bilious vomiting because of the obstruction and gut obstruction, abdominal distension, and feeding intolerance. Delayed presentations can be chronic refractory constipation, abdominal distension, and failure to thrive, failure to grow like normal. Okay. Diagnosis, again, it is the problem of the muscular activity, or the pressure inside that segment is very high. So when we do the rectal manometry, there is absent rectoanal inhibitory reflex. There is no inhibition to the spasm, and there is the whole area is in the phase of contraction. When we do the rectal biopsy, it is the gold standard for the diagnosis. Rectal biopsy shows area where there is a ganglionic segment, the area where there are no ganglion cells in the mesenteric or the mesenteric or the submucosal plexus. What is the treatment? Treatment is resect the area that is affected. Resect the aganglionic bowel and pull through procedure. What is the pull through procedure? Take out or pull out the normal segment down and anastomose it with the normal segment, and the rest, the area, we cut it out. So this is called a pull through procedure, which is the treatment for the Hirschsprung disease. So what is Hirschsprung disease? It is a disease in which there is a lack of the ganglion cells in lower part of the gut, and usually at the rectosegmoid junction in most of the cases. And child usually presents with chronic constipation. Sometimes they say thread-like stools also. And when you do the manometry, the pressure is too much high in that area, and there is lack of the reflux of the, there is no inhibition of the ganglionic cells. The ganglionic cells are not there to show the inhibitory response. So the whole gut in that area, in that affected segment, is constricted. So this is all about important pediatric cases. Any question about it? Any question? Any question about these cases? Okay, I have sent you the file on Word file on your WhatsApp group. All of you go through it, make groups, and discuss those scenarios with each other. You have a whole day today. Whole day means the whole night now. Discuss those cases. Some are from these lectures. Discuss the questions, how you will perform it, and make a PPT, make a PowerPoint presentation, any one of the group, I can ask them to present it. Okay, it's not like that one person will speak himself. Make the presentation, and any one of you should get up and present it to us. You will share your presentation to the whole class so that your friends can also see what you have gone through. For your own benefit, it is important that all of you should complete these scenarios, should go through these scenarios, and should come up with answers. But presentation, if not like that, one group for one case, you can do it. Second, I wanted to suggest you that these cases, the PowerPoint presentations that you will make, you will organize it as a case presentation. You will organize it like a case report, and you will upload it in the Moodle, where I have given it the student's assignment, or there is a folder there by the name of case report. Let me see what was that, just a minute. If you go to your Moodle page, it is there by the name of, just a minute. It is by the name of case report assignment. You will go into that, and you will upload it there by your name. Okay, so this is for all of you. Every week, every second week, we are doing it on alternate week when we are taking this tutorials. We are discussing 5 or more cases. So you have to prepare one complete case. You have to make a complete report about it, how the disease starts. You can add the scenario, and then you add your own things, like how is the presentation, how is the examination points, what are the things should be asked in the history, what is the examination points, and then how to investigate and how to operate, how to manage the patient. So this will be your whole case. You will make a PPT. Now from now onward, you will make a PPT. But before that, the cases we have done, you can make it on a Word file, and you can upload it by your name in the in that folder. So this is important because in the final exam, the logbook is as logbooks are not being given to you, you cannot fill your logbooks. This will be used as your activity, and it will be the 10 marks that you have to gain from that continuous assessment. So you have to perform it, you have to prepare it well, so that there will be no deduction of any mark from that. And this is must for every student. Okay. Regarding tomorrow's activity, make 5 groups, discuss those cases, make a small PPT discussing all the questions that have been asked, and then any of the group member will be asked to present that. Okay, so this is finished now. If you have any question, you can ask. If you have any question, you can ask. Okay, I'm ending the session. Where is Muhammad Hussain? Muhammad Hussain Zankarani is here. Okay, I was saying that on the Moodle, you have been given assignment folder. The folder is there on your Moodle account whenever you will open it. You have to prepare one case report. The cases we are discussing here in the tutorial, you can take any of them. And you have to prepare it properly. What was the presentation of the patient? What point should be asked in the history, examination, investigations, and then what you can do to manage that patient. But you have to make a case report like this, and you can make it on Word, or you can make it as a PowerPoint presentation and you can upload it there. So you have to be very careful in preparing it, because these are cross-checked also. It's not only me who will check these, Dr. Abdul Majid or even the quality people, they also check, and your marks are according to their opinion. So you have to be very careful while you are making it, because you have to be these are your 10 marks. So if you want to get full marks, you have to be very careful while you prepare it, and you can send it to me for cross checking. I will cross check it for you also. So this is must for all the student, because it is instead of your logbook part of the continuous assessment. Regarding the midterm, we discussed yesterday. I asked from you, and the students, they said that till week 4 we will take the lectures in the midterm. So I will put the lectures and the tutorials that we have covered in this period, in this whole 4 weeks, inshallah, in the midterm. And you have to be aware of the things that you have the lectures and the tutorials, also tutorials, if not as a separate topic, but the things and the cases we discussed, these all are important. Even the cases we discussed, the same or the related questions can be asked in the exam. So you have to read not only the lectures, but also those cases which we have already discussed. When is the final date for? Date for? I have not put the date, I think. I have not put the date. So let me see. Okay, this is start of the Feb. You can send it till the end of the Feb, 28th Feb. You can make it the last date. I will put it there. Inshallah, 28th Feb. You have 1 month to prepare these, and we will have classes and time during this all period. You have your final, I think, in the start of the April or end of the March. So before that, try to finish this thing in the Feb, so that we can give more time to the rest of the things. And regarding midterm, I think you will be notified about the date of the midterm in the 6th week. It has been, I think Dr. Samir has given some date, I'm not sure, 16th. It is 21st Feb. 21st Feb. 21st Feb is the midterm exam date, so you have to be ready for this now. Okay. Now, inshallah, if you have any problem, you can ask, and you can clear any problem if you're having. Okay, inshallah, we'll see. We'll meet tomorrow, and I wish you all make PowerPoint presentations. Okay, make some 2-3 pages presentation, so that it is easier for you to look again. If you want to recheck something, you can go through that slide. Just reading and not organizing your thoughts is not beneficial. You have to organize your thoughts. You have to make a PowerPoint, a small PowerPoint with it, not too much big, just small, one page for one question, and discuss what you want to discuss in that specific question or that specific part of the scenario. Okay, inshallah, we will see you tomorrow. Hope the best of luck for you people. Okay, assalamu alaikum wa rahmatullah. Any question? Any question? Okay. Assalamu alaikum wa rahmatullah.